Happy afternoon to everybody. Am I audible to you? Can anybody confirm? Dr. Aparna, are you there?
Yes, you are audible.
Can Aparna,
Yes, you are
okay, thanks. So, to start with, we have getting overwhelming response of this the Medal International Detailed Dentistry Congress 2025, and we are fortunate that we have got some 150 registrations from across India, and we are also happy that previously what we are getting that we have more registrations from colleges and all, from dental schools and all, but now we are getting registrations from the private practitioners who are practicing in field. So since it is a digital dentistry congress, so they are very keen to participate. So this time we are getting most of the registrations from the practitioners who are really practicing in the field and treating the patients with the upcoming technologies and all. So I'm just waiting. We have 16 participants. There are two format of watching this program. One is that anybody can watch the program on our website, iddcon.com. On the website, we are webcasting it, and we have given the provision of a Zoom. So anybody who want to enter into the Zoom room, they can enter into the meeting room and keep their microphone in mute state and their camera off, because that's why we are, because sometimes the participants are not serious, so we are giving the provision that try to watch the program on webcast only on a website. But if you want to ask the questions, if you want to really feel, you can join on a Zoom as well. So we are slowly and gradually getting the people who are entering our meeting room. So there are 90-20 people in this room, and I am hoping that there would be some 50-60 people who are watching webcast on the website. We have got 150 registrations. So it's now 3-6. There is a small shuffle in our program that we have brought Dr. Aparna Dave before Dr. Rujita Patil. So let me start, the formal inaugural talk. Uh, Dr. Aparna, are you there? Are you ready with your presentation and all? Should I, start my
Yeah,
inaugural
yeah. Yeah, my
interaction?
presentation is ready. I'll have to share it.
Acha, just hold on. I'm just give me 5 minutes, not more than that. I'll just summarize the thing why this IDD con is. So, distinguished guests, esteemed speakers, honored delegates, and all dear colleagues, a very warm welcome to each and every delegates who joined this inaugural session of this International Digital Dentistry Congress. This is first time we are doing this program, and it is of with immense pride and gratitude I am before you on behalf of MedSkill, National Health Academy, New Delhi, and Alamin Dental College, Bangalore. So we open the door for our hope. We are starting a new horizon. We are going into innovation and new technology. So just why we plan this? A lot of thing is happening on, say this digital dentistry and the modern dentistry, and there are many physical program are also being organized time to time. But we have given opportunity to the people who are not able to move from their locations, that there must be a virtual platform where we would be connecting and sharing our knowledges and all. So we are now in a new era where we have change our treatment plan, diagnosis, how to treat patient, how to engage with the patient, how to record the patient cases and all. So we are into artificial intelligence, we are into 3D printing, we have guided implantology. So the world is totally changed actually. And with this, we have Iddcon 25 was envisioned. We have a vision that we are providing a global platform to all our participants, all practitioners, researchers, dental, academicians, students, to explore and exchange idea on this virtual platform. And we are starting this journey to to just transform this digital dentistry. And our aim is not only to make a this technology and going in the technology front, but we also take care of the we should make it a patient friendly or customer friendly. So we have to more we have to keep our eyes on making our services accessible, affordable to all, so that we can move on easily. So with this note, there is some challenges we are facing in our this upcoming when we are switching from conventional methodology to more modern dentistry or digital dentistry. We have a adoption barrier, we have a low infrastructure, less in training, we have the our inertia actually. People are not accepting change in this any technology or anything. People are more comfortable with the conventional one which they have used to practice for a long. We have changed the workflow actually, that we have a new workflow, we have a new plan to do the things actually. So this is again we are having a problem. Then we must consider about the bridging the gap actually, what is which we are doing research on our academic institutes. We should be more make it implement on the field actually. So there must not be a gap actually, that what is what innovation and what research we are doing and what is being practiced in the field actually. And then our responsibility, because we are the torch bearers, we are the change makers, we are the leaders, we are educators, we are innovators. So what we supposed to do? We have to, consider, drive this digital change. We have to make the environment. We have to make the environment around our patients, our colleagues, our supportive staffs to, adopt this newer technology and all. And why we are doing this in 2025? We are bringing with we have the covering the topic of this prosto ortho. We are very good implantologist who would be joining tomorrow, and they would be letting you know that what is the new trend in implantology. We have, I think, 3 4 implantologists who would be renowned in India and who would be joining tomorrow. uh, then we have say 20 speakers, 20 to 25 speakers, good speakers. They have the in-depth experience in their field and all, and they are joining from different locations and all. So this is the advantage of this webinar or the virtual congress, that anybody who is sitting from Shillong or Shimla or Darjeeling or Cochin or Trivandrum or Calicut, anywhere. The speaker is joining from, say, Mumbai, Ahmedabad, Nagpur, Pune, Delhi, so Ahmedabad. So these speakers are joining from these places, and we would be sharing their upcoming things and all. Then we have the opportunity here. We have the opportunity to having our young clinicians, young researchers. We have getting, say, some 60 paper presentation abstract, though we are allowing only 10 paper presenters who are going to present the live in a morning tomorrow, on a Sunday morning. We have 5 students and 5 faculties who are going to present their paper tomorrow. So we have to think about this. And what makes this Iddcon unique is because we have the diversity of our audience. We have really, I told you that we have the private practitioners, we have the academicians, we have the students who are the, we have researchers who are doing research, we have industry leaders. So this is a very unique program, very unique audience. We are sharing knowledge on this platform. And I request all of you, this next, say, today 4 5 hours, and tomorrow we'll start by 10 and we close by 7 in the evening. So I request all my participants that actively participate, ask questions, share their idea, learn, implement what you gain from here in your field and your respective practices in institutions, and above all, to become ambassadors of digital dentistry, not just within our own setups, but across the border and in a healthcare landscape. So for this closing note, I conclude, I encourage you all to make it memorable, more meaningful. So I request you to connect, converse, talk, collaborate, and let us keep the spirit of this inquiry of innovation and throughout the sessions. So we have a multiple sessions. People are joining from different locations with different specialty, different background, and I'm pretty sure that at the end of the event you would be having enriched with your knowledge, understanding of this, what is the upcoming and newer technology in dentistry. So with this note, I'll start with our first speaker, Dr. Aparna Dave. Dr. Dave is a professor and head of the Department of Oral Pathology with over 2 decades of experience in teaching and research. And she did his UG and PG from the Government Dental College and Hospital, Nagpur. She specializes in potentially malignant disorder of the head and neck region. Dr. Aparna Dave has contributed to several national and international journals, publications, and including undergraduate and postgraduate education. She is actively involved in academic activities at the Faculty of Dental Science and in university level, and regularly participate in national and international conference. She is our regular speakers. I think, most of the time when we are organizing any program related to dentistry on the platform of National Health Academy and MedSkill, she is there with her experience, her presentation, her work actually, and it is very enriching for our audience and our attendees who would be coming joining this. Dr. Dave is committed to his profession, development both faculty and students, and encourage research collaborations in a department and institutes. So over to you, Dr. Aparna. You are the second speaker, but we have brought you before because you have some commitments, so you have to leave. So over to you. I think you can share your slide. You can open your camera, you unmute yourself, and join.
Okay, thank you, Dr.
Happy
Nurul.
learning to all of you. Yeah.
Thank you, Dr. Nurul. I'll share my slide. Actually, it's being shown as host has disabled participant. Kindly enable.
Just hold on, sir. I'm just taking.
We'll make it happen as co-host.
Yeah, Dr. Aparna, you can share your slide now.
Is my presentation visible?
Yeah, your slides are visible. You are audible. Yes.
And am I audible?
You are audible.
Should I start then?
Yeah, over to you, Dr. Aparna. Please start. Yeah.
A warm welcome to International Digital Dentistry Congress 2025. So let's begin with this session. Good afternoon, everyone. In today's world, digitalization is reshaping nearly every aspect of life, work, and various professional domains. Many of us are familiar with the advances in digital dentistry, but digital transformation is revolutionizing the other critical area of healthcare. And the field of pathology is no exception. In fact, the visualization of tissues and cells on a microscopic scale has undergone a revolutionary change through digital pathology. Today, I'll be talking about what digital pathology is, how it works, and many advantages it brings to diagnostic, education, collaboration, and research. Now, digital pathology is a cutting-edge technology that transforms traditional microscopic slides into high-resolution digital images. These images can be viewed, managed, analyzed, and shared using a computer and can be stored appropriately. So, instead of viewing a glass slide under the microscope, pathologists can easily retrieve and view the image of the entire slide on the computer. It's not just about imaging. Digital pathology also includes advanced software tools for image analysis, offering insights that go beyond what the eye can see through a microscope. It has truly revolutionized diagnostic pathology, making the process more efficient, accurate, and accessible. Digitalization has transformed all aspects of research and life. It is not a new tool, it's a new era. The field of pathology is no exception. Microscope-based pathology, which has existed over 100 years, has gone digital. This shift represents not just a technological upgrade, but a fundamental change in how we think about and practice routine histopathology. The digital pathology information system also helps to analyze information generated from the digitalized slides, which can be utilized for proficiency testing, research, and education. There have been several hurdles in the widespread adaptation of digital pathology. This has not been adopted extensively, and its implementation as a diagnostic tool has been low. Looking back, the history of digital pathology goes back over many years when specialized equipments were first used to capture images from a microscope onto a photographic plate. The concept of telepathology, transmitting microscopic images between remote locations, has been around for a long time. However, in the past decade, pathology has undergone a true digital transformation, moving away from conventional systems into an electronic environment. The introduction of slide scanners paved way for whole slide imaging systems. Slide scanners have improved in terms of their magnification, capacity, and speed. Some image management softwares have been integrated with the laboratory information system. This has further led to acceptance and expansion of digital pathology. Now, glass slides are not going anywhere, and for a good reason. Pathology starts with a collected tissue, and glass slides are still essential, even if they are scanned digitally at a later date. But today's pathology goes beyond tissue and slides. It's about improving quality, productivity, and achieving more consistent and precise diagnosis. At the same time, pathology cases are becoming more complex, increasing the demand for precision, speed, and standardization. At the same time, workforce pressure, such as increasing workloads, are putting added strain on pathology departments. Fortunately, advancement in technology, including high-speed scanners, AI-powered tools, and scalable cloud networks, have helped to ease out the burden. Considering the way today's pathology is changing, there has been advancement in technology, including high-speed scanners, AI tools, and cloud networks that are more accessible. Today's pathology needs new approaches. And when pathologists stop short of adopting digital pathology fully, they are missing out on the benefits that cannot be achieved with glass slides. Digital pathology is transforming how tissue samples are examined by converting into traditional glass slides into a high quality digital images. One of the core technology driving this transformation is whole slides imaging, also known as virtual microscopy. It involves scanning entire glass slides to create digital versions that replicate the look and feel of traditional microscopy. This incorporates the entire process of slide acquisition, where the slides are scanned using high-resolution scanners to produce digital images. Digital images are then stored and organized using a dedicated software and cloud platforms. Slides can be shared over network and can be accessed and interpreted remotely, allowing seamless consultation between pathologists worldwide. Advanced tool enables zooming, allowing measurements and permits annotations for further discussion and image analysis for precise diagnosis. Most software platforms utilized here mimic the traditional microscope interface, allowing users to toggle between fixed magnification or zoom continuously on a sliding scale, enhancing usability and familiarity. For acute image interpretation, display resolution and screen size are critical. The monitor resolution must match or exceed the quality of whole slide images. Otherwise, important details may be lost, especially at a high magnification, leading to pixelation and reduced diagnostic accuracy. Use of high resolution display ensures that digital slides are viewed clearly and interpreted precisely. End-to-end color calibration ensures color stays consistent throughout the workflow. In addition, due to the large file size of the images, a high bandwidth internet connection and adequate storage infrastructure are essential for smooth access, viewing, and archiving. Properly trained staff, appropriate quality control steps, and regular maintenance of both hardware and software are essential for ensuring the accuracy, reliability, and long-term success. Now let's look at the key benefits over traditional microscopy. Digital imaging offers objective, accurate, and reproducible image analysis, which enhance the reliability of medical interpretation. It enables faster and more objective diagnosis, reducing variability between observers. With easy access to previous cases, clinicians can make better comparisons and track disease progression over a period of time. Features like digital annotations and zoom improve the clarity of visualization, making it easier to identify important details. Additionally, AI-driven algorithms can detect patterns and abnormalities that might be missed by human eye. Finally, the availability of archived data supports predictive modeling and research, contributing to a continuous improvement in the healthcare outcomes. Digital slides offer significant advantage in terms of accessibility and efficiency. They can be retrieved within seconds and accessed simultaneously by multiple users, making collaboration much easier. Since there is no need for physical slide handling, delays are minimized, leading to a faster turnover time in diagnosis and review. Additionally, digital systems allow for flexible scheduling for discussion, especially for remote cases review, which supports timely expert consultation regardless of the location. Digital pathology significantly reduces the risk of commonly associated with traditional slide handling. Since there is no chance of breakage or damage of the slides, the chances of loss are eliminated. Barcode tracking further enhances identification, accuracy, minimizing mix-ups, and ensuring the correct slide is reviewed for each patient. Digital slides are also highly reproducible, making them ideal for training purpose or reanalysis when it is needed. Additionally, the use of standard imaging ensures consistent quality across all slides, improving reliability in both diagnosis and research. One of the most transformative aspects of digital pathology is its ability to bridge geographic gaps. Digital slides can be shared instantly, enabling real-time collaboration between the specialists, even if they are located in different parts of the world. This means pathologist is no longer needed to be physically present in the lab. cloud-based platform provides secure and flexible access from virtually anywhere, supporting remote work. This connectivity is especially valuable for pathologists in rural or underserved regions who can now consult with international experts. In addition, laboratories can expand their services across borders, delivering high-quality diagnostics to broader populations. Remote access also supports flexible working arrangement, promoting work-life balance without compromising the diagnostic quality. Efficient storage and retrieval are essential benefits of digital pathology. This system allows for quick retrieval of slides even years after initial scanning, ensuring all data remains accessible whenever needed. Centralized data management supports long-term case management, facilitates audits, and enables effective comparison between cases. This approach not only saves valuable physical space, but also improves overall organization. Large IT and database structure and appropriate backup and retrieval procedure needs to be created. Instead of physical space for glass slide, a significant digital storage space is needed. Digital pathology has been widely adopted in both undergraduate and postgraduate training programs due to its many educational advantages. It offers interactive visual slides that allow students and residents to engage deeply with the material. This can also be used for teaching at conferences and visual workshops. It provides equal access to high quality standardized resources and ensures a consistency learning for all. Moreover, digital pathology supports remote learning and self-paced study, enabling learners to explore content at their own convenience while using interactive annotations tools to enhance understanding. Additionally, it integrates various online platforms, making it versatile and powerful tool in modern medical education. Digital pathology is driving innovations in diagnostics through various ways. Quantitative image analysis provides precise and measurable insights, allowing researchers to extract detailed information from tissue samples. By aggregating digital pathology data, large-scale studies and biomarker discoveries have become possible. Remote collaboration research is greatly facilitated as digital slides and data can be shared instantly amongst researchers worldwide, promoting global partnership. Additionally, enhanced reproducibility is achieved through digital records, which ensures that research findings are consistent and can be replicated. Whole slide images serve as an enabling platform for application of artificial intelligence and digital pathology. AI and digital pathology together are transforming diagnostic medicine by integrating clinical, histopathological, and genomic data through advanced AI and machine learning tools. These AI algorithms can analyze vast data sets to detect subtle patterns that may be missed by human eye. By combining human expertise with AI augmentation, diagnostic errors are reduced and the overall diagnostic process is accelerated, leading to faster and more reliable patient care. Additionally, large volumes of image data generated enables AI to uncover new disease markers, identify patterns, and predict treatment responses, driving innovation in personalized medicine. To develop a successful pathologic AI model, it is essential to carefully select the appropriate image type for the specific application, utilize large-scale data, apply rigorous image standardization, and color normalization. Now, the common concerns such as microscope still work fine, or the high cost factor, or saying that the integration is too complex have been the major hurdles in implementation. In reality, the initial investments in digital pathology face off over a period of time. This is achieved through save time, reduce diagnostic errors, and increase capacity for handling multiple cases. Furthermore, comprehensive support, thorough training, and phased out adaptation helps in easy transition, reducing resistance, and ensuring successful implementation. However, challenges such as need for reliable internet with sufficient bandwidth, availability of high-resolution systems at both ends, high investment, and reluctance to switch to digital workflow remains a major issue in smooth implementation. The future of pathology is undeniably digital, marked by transformative advancements that promise to revolutionize diagnosis. AI-powered tools will enhance the accuracy and speed of diagnosis, enabling pathologists to detect disease more effectively. Predictive analysis fueled by extensive image database will allow for early detection and personalized treatment strategies. This shift toward precision diagnostic is expected to significantly improve patient outcome by tailoring interventions to individual needs. Additionally, the development of a connected global pathology ecosystem will facilitate seamless collaboration and data sharing amongst healthcare professionals worldwide, driving innovations and elevating standards of care everywhere. To conclude, digital pathology represents a major leap forward in how we view, share, analyze, and learn from tissue samples. Digital pathology is just not a tool, it's a transformational shift. It brings in greater accuracy and speed, enhanced collaboration, improved workflow and teaching, global accessibility, and innovation. Whether in diagnostic, education, or research, digital pathology is redefining the landscapes of modern pathology. Now, the question is no longer if digital pathology should be adopted, but how quickly organizations can embrace its potential. Thank you all for a patient hearing.
Thanks, Dr. Aparna, for sparing your time and all. Any question from any audience if they want to ask question? Otherwise, I will move to the next speaker. Any question from anyone related to digital pathology? If you want to ask question, you can put it on a chat box as well. Chat facility is also available, so you can ask question in the chat. So we are not getting any more question. With your permission, Dr. Aparna, you will stay with us if you allow.
I'll be there. Yes, I'll be there. And thank you for giving an opportunity to speak up.
Yeah.
This branch is little different, but yes, the digitalization has brought a lot of changes in pathology part also.
Yeah.
That is what I wanted to bring around.
No, it's a very enriching, presentation, and very crisply completed, summarized in say 21, 20 slides. Actually, it's a very a good enriching experience to all our attendees and all. So, any question again? I'm just requesting. If there is no any question, Dr. Aparna, with your permission, we are moving to our next speaker,
Okay,
Dr.
thank you
Rujita
so
Patil.
much. Yes, thank you
Yes,
so
yes,
much.
yes. Yeah. So, Dr. Rujita, are you there? Could you please unmute yourself? Say hi. Are you there? Yes.
Yes,
Good.
yes, Priya.
Yeah. So, Dr. Rujita Patil, she is say organizing secretary of this International Digital Dentistry Congress 2025, and she is one of the factor with her guidance and support. We are able to do this program. Dr. Rujita is MDS from university rank holder, and she did PDCR, that is Professional Diploma in Clinical Research, from New Delhi, and she is working as assistant professor, Department of Periodontics, Al-Amin Dental College and Hospital, Vijayapura. Al-Amin Dental College is our academic partner in this program, and she worked in oral cancer screening consultant at COPMD, and she is also managing editor in the Oral Pathologist magazine. And she is the managing director at Advances in Multidisciplinary Healthcare Research Journal and Government of India Certified Clinical Research Trainer, co-authored many books she has written, and she has published many papers in various international and national journals. So, if I missed anything, Dr. Ujita, you can add on your introduction, and then you can start with your talk actually.
Yeah. Thank you, Dr. Nurul. Thank you for the opportunity also. And also, good afternoon, everybody. So, shall I start my presentation, Doctor?
Yeah, you are a co-host, so you can share your slide and you can start your presentation.
Okay, yes. Is my screen visible?
Your screen is visible, Dr. Patil.
Yes. Okay. So good afternoon, everybody. Today, I will be talking about electronic health records in dentistry. So electronic health records is basically, these are the electronic version of a patient medical history, which is maintained by the provider over time. And they may include some administrative clinical data relevant to the patient care, and also including patient demographics, their progress notes, medications, past medical history and immunization, laboratory data, radiological reports, and all of this are stored. So this is an overview about what electronic health record is. And also these days, we can see that 24/7, the hospitals are generating this kind of data. So every minute, some or the other data is received by the hospitals. So this has to be maintained properly. So for maintaining and managing and storing of such data, electronic health records have been put forward. So their purpose is to basically better the better and evidence base that can translate into better treatment at the lower cost, and also avoid repeated unnecessary investigations. Like for over the past, like probably 6 months before, the patient has got a blood profile done. So there is no need of again repeating it every 3 months or every 6 months when the patient visits. Patients might lose their records as well, but it is stored in the EHR. So when the doctor goes back and takes a look at the patient's medical history and other laboratory history, then they will find this record in their EHR system. Okay. So this can also help in predictive analytics to support the personalized care, improved health policy decisions based on better understanding of underlying issues, all translating into improved personal and public health. So if we see the market of the EHR, that is, it was around 29 billion US dollars in the year 2020. This is according to market.us media, and we can see that it is exponentially increased is projected to be increased by the year 2027 to 47 billion US dollars. So that is a huge scope, and also we can see how it is being adopted fastly in the countries. So the adoption rate you can see in the different countries, again, it has been put forward. And highest you can see is South Korea, Norway, and also US, South Africa, Japan. And definitely India is still lagging behind. That is 25% have been adopted when it comes to EHR. So we will see what reasons are there behind this, the lower rate of adoption also. What is the difference that exists between these different countries? So EDR, the electronic health records that are used for dental purposes, are again named as electronic dental records. So there is definitely rapid increase in the chairside computing and EDRs in the dental practices worldwide. And the current wave towards the adoption of the EDR is also progressing, and it is rapidly growing. Many dentists have started using this management software because of its easy availability of computers, and also they can incorporate newer technologies for recording case histories, devising templates, and making the treatment plans, and also to hand out the instructions to the patients and integrate the digital imaging and digital pathology kind of concepts in their clinic, which will make them more progressive and more eye-catching to the patients as well. So what are the different challenges the dentists are facing regarding the paper dental records, on-paper dental records? That is filing and storing these documents. It is a huge task. Again, you need a different personnel. The number of workers of that personnel will also increase. And patients lack or lose paper histories. This I already mentioned that the patient, whenever they come back, they might not always, have their patient histories and also their previous images, radiological images, lab investigations, whatever has been done, they tend to lose it. So, but that is if you have an EHR system, that problem can be solved. And delay in retrieving paper records. So if the paper records have been stored, you have to go back, find that paper records, and then check for what was the medical history, what are the allergic history. So it takes a lot of time. And time constraints on record preservation, challenging to obtain the reliable dental care history. So sometimes if anybody has missed any point, the dental assistant or anybody has missed any point of recording any dental care history, again, that is a challenge. These all can lead to reduced quality of care, and also increasing volumes takes up a lot of storage area. There has to be a dedicated storage area, and that itself is costing even both the private and the government sectors a lot of money. That this much square meter of room has to be dedicatedly provided for keeping this huge bulk of healthcare records. We know the increasing population of India, so the healthcare records also, they keep on piling up. So that also, keeping in mind the cost factor, is also a problem for the healthcare professionals. And again, potential diagnostic and treatment errors, and the ease of sharing the data among the different dental centers or other dentists. If you want to take an opinion from the other dentists, that also becomes a challenge. Next is EDRs is used by dentists to document patients' dental history and precise information. So systematic data control and collection is one of the advantage of EDR. It facilitates data storage and access, supports administrative as well as managerial processes, guides the public health policies, and also can be utilized in research and education. So while creating these public health policies also, if you have a data backed up of 20 years, 30 years of what exactly are the major troubles or the underlying issues which patients are facing, that will also help in coming up with the healthcare policies in a better way, and definitely for again evidence-based clinical practice, and research is a big point as well here, along with the other additional outputs functions. EDR helps in quicker and easier access to dental care information and history, and also improves communication with other dentists. EDR is essential for dental consultation and rapid response in emergencies. You can just go and see what are the allergic reactions, or if any emergency has happened on chair. It is very easy to access the patient data, especially those who are having a complex medical condition. So there is another thing called as the clinical decision support system, which are included, integrated along with this EDR system. It has been integrated. Not every EDR system has this, but yeah, clinical decision support system provides the patient-centered clinical recommendation in real time. That is, if so-and-so information of the patient has been put along with the demographics, the medical history, the case history, past history, medical history, allergic history, and other things, a proper decision. Like, for example, there is an oral cancer patient and there is caries happening, like too much, and mucositis, or there is a decision system that is provided by the EDR itself, and it helps in diagnosing and also giving treatment to the patient for the dentist. So what are the key components? Patient demographics and medical history. These are the key must components which are there in the EDR system. Clinical notes and also documentation, case management and treatment scheduling, image and radiographic integration, medication and prescription control, billing, insurance, and financial management. So these are the key components. Benefits of EHR are enhanced patient safety and care, efficient data retrieval and record keeping, improved collaboration and communication with the co-dentists or other healthcare providers, data-driven decision making, adherence to law and regulations, because there are some standards set by government for the EHRs. Let us see what is the scenario that is in the developed countries like United States. So this is a paper that has been published in the year 2017 by Acharya et al. It was an update on electronic dental record and clinical computing adoption among dental practices in the United States. Here, if you see that this diagram, if you see, then you can understand that it basically shows the information storage methods of major clinical and administrative information in dental practices. When it comes to the information type, whether they have, this is the information type, and whether they have stored it in the paper form in the computer, or they have used both paper and computer, or they've used none. This is how they have bifurcated. Okay. And highest would be the expense reports, that is 67%, insurance details, that is 71%, extra oral images of the patients, 62% have used computer for storing extra oral images, and intraoral images also stands at 64%, and 76% of the dental practitioners have used computers for patient accounting and billing, and patient appointments as well, that is 77%. And if you see here, radiographic images, which have been used by 64% of dental professionals in the USA, which they did a survey. Okay, so here definitely for other purposes like medical history and all, medication, oral health status and all, we can see either their use of paper and computer have been equally distributed, or the computer-based usage is comparatively less than the rest which I mentioned right now. So now if we see this expense reports, or you can see the patient accounting, billing, insurance details, and patient appointments, these are basically performed by a front desk personnel. It is not the dental practitioner or dental assistant as such. So you can see that the most of the adoption of the EDR is by front desk personnel, and dental assistant primarily in the intraoral images and radiographic image storing. Dental hygienists, usually they are used for capturing the periodontal charting and associated problems. And dentists as such are for health status, e-prescriptions, intra and extra-oral examination, test results, risk assessment, even risk assessment, caries risk assessment, cancer risk, oral cancer risk assessments. Also, this CDSS system, if it is incorporated, it shows for one of the particular patient by recording its the smoking or drinking habits and all of those is shown by the EDR. Problem list, treatment plans, diagnosis, prognosis, progress notes, complete treatment. So we again see definitely there is increase in the percentage of adoption of EDR in the developed country like US, but still dentist as such compared to front desk personnel, we can see there is a lot of difference that is going on. Again, the major work is done by front desk personnel and usage also by of EDR by front desk personnel. Next is the demographics. If we see, if we see the demographics, we can see that 52% of them have adopted EDR in their clinical practice. So that is a good number. And if we see age-wise, definitely the age group of between 20 to 39, 73% have adopted. That is elderly a little bit, they were reluctant to use because they have been using paper-based in their earlier practices. So the adoption, the change in their practice was difficult for them to move from paper to the electronic method. So next was gender, definitely. Again, females comparatively 65% compared to males. So females have adopted it more than compared to males. And years of practice also, if they compared, less than 26 years, those who are in practice with for less than 26 years, 63% of them, they have incorporated it compared to those who have had their practice of more than 26 years. Then practice type compared to solo, the group practices where like dental specialty clinics, where multi-speciality clinics are there, where different specialties are working together, they have adopted EDRs more compared to the solo practitioners. Now, this is another diagram which they presented in this study. That was the word count summarizing key themes. That is, the upper box shows the A, which this shows the advantages of those who have adopted. These are the responses of those who have adopted EDR in their dental clinics. And B shows the disadvantages which they faced with the EDR system. Okay, so you can see the size here, like ease of access, sharing info, portability. This coincides with the frequency of response. Like most of them said that ease of access, sharing the information about the patient, and portability, the organized, it was more organized. So these are all the major advantages which they mentioned. And again, the trouble was like, again, training the personnel, data entry, data security. They were not confident about whether the chances of computer crashing or there are any power outages, what to do in such cases. So they were a little bit, they said that they were and also the reliability, doubt in reliability was the factor, which they said are the disadvantages of using EDR is what they have mentioned. This is again a very nice image wherein provider perceptions of electronic dental records have been given, whether they agree, disagree, or they were undecided. So regarding the security, like whether they were secure, data was secure, patient data, 36%, that is, it was equally distributed. If we see that whether the EDRs improve the efficiency of the dental staff, and most of them agreed for that. And if, cost was again a major factor, whether the cost is worth the what work the EDR is, output the EDR is giving. Like 40% of them disagreed that the cost was more. That means they were in terms that the EDR is helpful when it's adopted in the clinic, and also it improves the patient care. That was also majority of them agreed for that. And they all the dental practitioners who are already existing, they also said that incorporating this EDR system in their new practice would help enhance the dental practice, and it is a good practice to be done. And also legibility also is increased. For example, now even e-prescription is a part of an EDR system, though using a handwritten prescription compared to that, having a computerized typed prescription is again better. So that is also again a point to be considered. Next, EDR adoption rate in US itself. These are again done by two and three different authors. In the year 2005, it was 25% by dentists, and 2006 or 7, it is 55%. And the year 2017, it raised to 75%. So you can see how exponentially the adoption of EDR is growing. One of the very fascinating by US dentists compared to the Medicare, Sayo et al. Hello.
Yeah, Dr. Ruchita.
Okay, I'll just share. Maybe there was some connection glitch here.
It's visible now. Continue.
Oh, okay. So one of the reasons why you can say that the adoption rate was higher among in the US was the high-tech EHR incentive program. So it is a health information and technology for economic and clinical health. This is an incentive program which is part of American Recovery and Reinvestment Act. They basically encourage this program. Incentive program was aimed to encourage the adoption and meaningful use of certified EHR among the healthcare professionals. And even though the dentists were unfamiliar with the incentive program, they have adopted it in a better way. There is an incentive program, and what happens is they kind of take care of the financial aspect also. So this is a financial help and aid to the healthcare professionals, which is provided by the US government over there. Another benefits is the cost or expense of EDR is also a point to be considered. Why it was there is a hindrance in adoption. Cost benefit ratio, time to convert from paper based to computer based, and poor usability remained one of the top barriers here. So EDRs, one of the top disadvantage is the regarding the reliability with the technology, because not every dentist is tech friendly. So that is one of the reasons why it happened. Scenario in countries like India. Here is a beautiful paper which was published in the year 2023 by Sultan and Amina et al. And they tried to evaluate the knowledge and perception of EHR and computer-based maintenance among the dental professionals. And they also highlighted what is the current state of EHR in India while discussing the financial and legal barriers. So if you see that the 49% of respondents, around 300 plus dentists were again surveyed here. And they said that they use some kind of chairside computers in their practice. And most of them said that they have to always use a computer for their practice. And do they use internet? And 64% said that they use internet. And for where do they record their diagnosis? Most of them said that it is on paper. For again, chief complaint recording, most of them said it was paper. For internet using was basically again towards billing, accounting, appointing, and other demographic details. And rather for whenever it comes to treatment plan, radiographic data, they have used again, sometimes in the paper, and this has been equally distributed, but similar to the ones that is adopted in the US. When it comes to knowledge of EHR and EDR, 28% said that They feel whether the patient data is secure regarding the leakage of the sensitive information of the patient. 28% were concerned regarding that. And 42% were unfamiliar with any kind of technology, EHR or EDR technology. And again, lack of workforce for entry, that is training the personnel. This is again a major barrier. And cost. Cost is a very, high expenses is one of the reasons why the adoption of EDR was not, so well in India. So these are some challenges they have put. You can just go through this study. They have beautifully mentioned all these challenges. And yes, but definitely 75% of them agree that EHR should be, incorporated in, or EDR should be incorporated in a dental clinic. So EDRs basically work on this quadruple aim, that is lower cost, better health outcomes, improved clinician experience, improved patient experience. E-prescription, as I said, is part of an EDR system. It is another dimension that is added to the medical horizon through EHRs. So Kaushal et al. Again did a study, a beautiful study with 12 community-based practices, and found out that the error rates, discovered that error rates fell from 42.5 per 100 scripts to 6.6 per 100 scripts. Nearly a seventh of the introductory level in just 1 year of adoption of e-prescription. This is a huge difference. 42.5 to 6.6 per 100 prescriptions. This is a huge drop down in the errors in the prescription. So we can see that India is gradually upgrading its IT infrastructure to implement this e-prescription format and also control the online sale of medications and restrict illegal manufacturing. So when it comes to effect of EDR on the patient, 27.7% of practitioners reported using hybrid method. Okay, so face-to-face or through electronic media. But if you compare this with the US study, there were the 79% of dentists used either, and 30% of them employed the digital aids like softwares. So there is a difference in the adoption, is because in India, the dentists fear that there could be a disconnection from the patients, as a face-to-face, interaction with the dentist and patient regarding also instructions and, all of that is very important and crucial, is one of the reasons why this how it can affect the patient outcome is what the study says. So you can see the state of health records if we see here. Among various concerns in implementing EHR, that is risk of computer system crashing. This is one of the serious concern. Then which is followed by lack of workforce for data entry, and dental assistants' reluctance or even inefficiency to feed the data into the computers. This is a third point that is there in the barriers. And 28.2% of practitioners were unaware or unfamiliar with any kind of such technology like EHR or EDR systems that is ongoing. State of EHR in India, 88.1% who participated in the study, they stressed for adoption so that the practice is advanced. And 75.4% of participants also they intend to incorporate EHRs in their dental practice in the upcoming years. So commonly used EHR systems in in India also, if they saw, that is one is PROMIS, that is problem-oriented medical information system, and which was again followed by Regenstrief medical record system, RxMT, ACE Dental, Dentrix. These were the commonly used EHRs or EDR systems in India. Now, definitely the big corporate hospitals, and also Indian government tertiary healthcare centers like PGIMR, and corporate hospitals like Max Health, Apollo, Shankara Nethralaya, Fortis have implemented EHRs for covering again registration, laboratory bills, laboratory data and bills and insurance and all these categories. So this shows that there is definitely a financial budget is one of the major hindrance in our country, and the lack of ICT infrastructure and incentives to install them in the private practice for the betterment of society is another noteworthy rationale which we have to take into consideration. Okay. And 54.2% respondents strongly agree that without proper training and also hands-on practice, the EHR or EDR system will not be used to its fullest capacity in a dental system. So almost 45% of practitioners were unaware that any certified EHR programs exist in India or not. So let us see what is the certified EHR system. A certification for an EHR system is usually provided in other countries like US. But yes, in India, this is one of the lacking factor, as there is no certified EHR that exists in India. But yes, standards have been set forward by Ministry of Health and Family Welfare in India to ensure interoperability and standardization of healthcare information. ONC this provides a certified EHR. Okay, this is a national coordinator for health information technology. It ensures information technology meets the national standards for data security, data accuracy, security, and interoperability. Okay, so this is a voluntary program, but certified health IT, and it is often a requirement in various federal, state, and private programs. Okay, so we have ONC over there in the US. Okay, and it ensures that the software companies which produce this EHR systems, they meet the specific technical and functional requirement of the EHRs and other healthcare systems. So in India, what we need to understand that is Ministry of Health and Family Welfare has taken up a major initiative, and the standards, they have put forward certain standards for any EHR or EDR system that comes into picture in the India. First version of these standards was released or published in the year September 2013, and the latest version in the December 2016. And they have taken, best standards. They have chosen from the available standards which are there, which other countries are utilizing. They have adopted these standards and they have come up with one. And majorly to, standardization, they have done this to bring standardization, homogeneity, interoperability in capture, storage and transmission, and also use of the health information across this various health IT systems. So again, the Ministry of Health and Family Welfare, basically, they have established a National Resource Center for EHR standards, okay, at CDAC. CDAC is the Center for Development of Advanced Computing in Pune. This helps in accelerating and promoting adoption of EHR. So the NRCES, that is National Resource Center for EHR Standards in India, it is only single point contact wherein the development assistance of EHR system goes on. And they are the ones who are responsible for, training also, and also implementing the other standards and everything. So NRCES is completely dedicated for the electronic health records. You can see they provide education, training, tools, technology, support, license. If you go to their website, you can have a complete this thing. These are the EHR standards which they have incorporated. Now, standards for interoperability from Government of India. Now, if you see this Bureau of Indian Standards, which was formerly ISI, they have set standards for relevant electronic health record implementation by various vendors which are dealing with the clinical data. So that standards they have taken and incorporated in this. So SNOMED CT is again a standardized way to represent the clinical phrases which the clinicians are using. So these phrases, they have taken it from SNOMED CT. If you see HL7 International, this is standards for transfer of clinical and administrative data between the software applications by various healthcare providers. So this standard has to be, incorporated in that EHR system. Only then the transfer of the data can happen. So Digicom is again what is the standards, how you can communicate and manage the medical imaging and its related data. So this is again DICOM. ISO standards are available. These are the different LOINC standards are there. This LOINC is again for identifying names and also codes for identifying health measurements, observations, and documentations. There is a standard for all of this. These have been included by LOINC, WHO standards they have taken, IEEE. IEEE has put forward health informatics standards for medical devices. So that also has been incorporated by NRCES. Open EHR is a open electronic health record system, which is globally accepted. So they also have some universal interoperability, standards which they have set, and that have been again incorporated in this thing. So what are the legal steps or legal framework that have been taken by the Government of India? That is again 2016, the updated version by Ministry of Health and Family Welfare. There is something called as Disha Act, which comes under, which is to ensure that the regularity, security, and privacy of the electronically stored data is followed by creation of National Electronic Health Authority of India and Health Information Exchanges. This is a significant step. Disha is kind of a counterpart of HIPAA. HIPAA is a big act for ensuring the patient security data and all of that, but Disha more concentrates more on healthcare data, which was put forward in 2019. We have National Digital Health Blueprint, which again introduced in 2019, designed to build a global healthcare network, electronic health registers under the National Digital Health Mission. We have Personal Data Protection Bill that was again put forward in 2019. So these are some legal, steps taken by Government of India. And in case of US, Australia, and UK, they have been quite successful in encouraging encouraging the adoption of EHR. One of the reasons is that incentive programs offered by governments to put forward by the national bodies to private practitioners, allowing their services to be covered under government insurance schemes. So insurance schemes is something they have used, so adoption also has been faster. What are the barriers in India? Risk of computer crashing, lack of workforce entry, and computer illiteracy, 35.5% amongst the practitioners as well as dental assistants. Next, 28.3% of participants who were surveyed here were concerned about patient data security and leakage of information, lack of government policies and incentives, absence of uniformity, and language and software infrastructure. This was the scenario of India. And if we see in Iran, again, a beautiful study was done in the year 2024. And here they have ethical legal barrier, policymakers, turnover rate. In one or the other way, it remains the same for all the developing countries, that is training the staff, infrastructure, lack of suitable legal infrastructure is not there. Cost of purchasing system and deploying and implementing this EDR is also an important point. If we see a scenario in Saudi Arabia, again, it remains the same. Computer experience for healthcare professionals is low. And, perceived ease and also technical limitations, that is software knowledge of illiteracy, that is also a part. Lack of quality in patients' information, lack of EHR standards, and also like hospital size and care, the EHR system, it also varies with the size of the hospital. So these are some common changes, barriers which we have seen and differences amongst the developed and the developing countries in adoption of EHR. So transitioning to electronic dental record system is not merely about keeping pace with technology. It's about providing better care, meeting patient expectations, and ensuring regulatory compliance. So thank you all for patient listening.
Thanks, Dr. Rujuta, for joining, giving your precious time and throwing a light on electronic medical and dental records and how we are progressing slowly and gradually. And in upcoming days, there would be, 100% we would be switching to EDAR, but we have only, say, 50% we have regulations and all. So we are expecting anybody who want to ask any question, ask Dr. Rujuta. She has expert in medical records and all. So you are running your clinics, you are giving consultation to the patient and your departments and all. So if you want to keep the records, if you want to pass the records, you can ask questions from Dr. Rujuta, and she may guide you with different devices and softwares, and what are the standards followed by international and global organizations. So anybody who ask any question, they can ask question here, or they can put the questions on chat box. So no question, Dr. Rujita, you may stay with us. Maybe
Yes,
if somebody is asking question, we'll take your question post Dr. Uruj Desai's talk. So
sure, sure.
with your permission, we are moving ahead with our next speaker,
Yes,
uh,
doctor.
Dr.
Thank
Uruj Desai. Uh, Dr. Uruj,
Hello,
yeah,
sir.
yeah,
How are you?
yeah, I'm doing good. How are you?
I'm
Good.
great.
Yeah. So, welcoming Dr. Uruj. She is also in our organizing committee team, and she is very instrumental in designing, implementing this program. And she helped the organizing committee to, make it a successful program. And she is speaker as well here. So, apart from organizing, managing the from backend, she is also taking part as a speaker in this prestigious this International Digital Dentistry Congress. Just to introduce Dr. Uruj Desai, she would be talking on partial bonded restoration. Dr. Desai Khan is a skilled endodontist and aesthetic dentist with a strong passion for creating beautiful, confident smiles. She has deep knowledge and experience in aesthetic dentistry and smile designing. In last year, she was awarded the Aesthetic Dentist of the Year for her outstanding work in the field. Dr. Uruj has also published several national and international research papers, making contribution to dental science. So, Dr. Uruj, if we are missing anything, you can add on in your introduction so that our audience would understand you well, and then you can start your talk. We have made you, I think, co-host, so you can easily share your slide and you can continue. Over to you,
Okay.
Dr. Uruj.
Yes, sir. So, hello, everyone. I'm Dr. Urush Desai. I'm a conservative dentist and an endodontist. And today we'll be talking about partial bonded restorations. So, is it visible?
Yeah, your slides are visible. Can you
Yeah.
go to, yeah, visible.
Yeah.
Yeah.
Great. So, today we are talking about something which is called partial bonded restorations. So, before getting on to the topic, I want to explain to you all two important terms in terms of partial bonded restoration. So, let's take a realistic example and compare both. So, firstly, if you want to build a house, right? So, you have seen some construction site going on. So, what exactly they do? They just dig it and underground and build pillars inside, and then they build the house onto that. Correct? So, comparing it to the tooth structure, we have something which is the foundation of the tooth structure. If that foundation is well enough, then the longevity and the integrity of the restoration will last longer. So this foundation is the cervical area of the enamel and dentine, or the enamel and dentine in the cervical area, which is present, which we called as a biorib. This is the foundation. If this is not hampered, then the longevity of the restoration lasts longer. And onto that, we give a restoration which we call it as a biodome, which surrounds the tooth or the biorem in a dome-shaped manner. Now, suppose you have a broken window in your house, right? A broken door or a broken window. So, do you replace the entire broken window or a broken door, or you just replace the entire house for that? No, right? You just replace the window or repair the window, whatever it is necessary. You don't replace the entire house just for a broken door or window. Then why don't we apply this same principle in dentistry? So why is it necessary to repair everything and then go for a full coverage restorations? So here comes the most important term, that is PIAR, which is posterior indirect adhesive restorations. Okay, so the basic aim of PIAR is to repair only what is necessary. You do not need to do an entire crown for that or a full coverage restoration for that. So initially dentistry was all about drill and fill. We used to drill through the tooth structure and then fill through the canals and the coronal structure, and then we used to do a full coverage crowns, and then we used to fabricate a crowns by taking impressions or digital scans. But now, as the technology is advancing, as the dentistry is becoming digitalized, we are into an era which is known as preserve and bond. So we are into an era where we preserve as much as healthy tooth structure is available for us. Why? Because we want to maintain the healthy tooth structure, which will ultimately help us increase the longevity of the restorations. So there are various options available in partial bonded restorations in comparison to the full coverage crowns, that is inlays, onlays, veneer lays, tabletops, endo crowns. Various options are available. We'll see about all this in our upcoming slides. So, as I said, our aim is to repair only what is necessary, thereby being efficient, conservative, and smart. So let's talk about case selection. What kind of cases exactly we need to go on for partial bonded restoration? Whenever there is a mild to moderate tooth structure loss where there is no circumferential damage, as you can see here, there is no circumferential damage to the tooth structure. The circumferential enamel is still present. And as you can see in this image, the tooth is very much grossly decayed, right? So in that, the enamel that is present is very much less. So such cases are not indicated for partial bonded restoration, and they are indicated for full coverage restorations. While other cases where there is a mild to moderate carious lesion, or say class 1 caries or class 2 caries, in such cases we can opt for partial bonded restorations. Also, whenever there are worn out occlusal surfaces, some atreated surfaces, some localized atresion is there, then in such cases you can opt for this. Also, when there is an extensive caries which is limited to 1 or 2 surfaces only, just 1 or 2 surfaces, or we want to replace any old filling or any failing restoration, then we can opt for partial bonded restorations. Also in aesthetic cases where we have chipped anteriors, where we have diastema closures, or where we need to repair any fractured tooth, any at least class 1, class 2 fracture, or if we have fluorosis in such cases, we can obviously mask it with veneers or partial bonded restorations. We can do it with veneers, onlays, whatever is convenient. And the last and the most important point that we need to consider is good oral hygiene and periodontally sound teeth. If the tooth has a class 1 carious lesion, but if it is a grade 1 mobile, then there is no point of replacing it with a partial bonded restoration, right? So the tooth needs to be periodontally sound. The gums and the bones should be healthy enough to give the support and the strength to the tooth structure. Okay. So what are the key important things or the key treatment planning considerations that we should be keeping in mind while planning out for the partial bonded restorations? So whenever a case comes to you, in the first and the foremost appointment, you should be knowing that I want to do a partial bonded restoration in this case. Okay, so at the first appointment itself, you should be clear in your mind that I have to do this case in a partial bonded restorations. Then things will go easier with you. So firstly, it is the thickness of enamel, or how much amount of circumferential enamel is present. As you can see here 360-degree circumferential enamel is present, and also there is a quite good thickness of enamel, at least 1 to 2 mm thickness of enamel is there. This will thus help in better bonding, and ultimately it will help our restoration to last longer. Another is the material. What kind of material do you choose? Are you going for composites or are you going for ceramics? So initially, indirect composites were used, or in this restoring just the defective portion or the carious portion of the tooth structure. It was considered as the middle path, as it had aesthetics of ceramics and the flexibility and the repairability of composites. But that there were various limitations of indirect composite restoration, such as they were not reliable in bonding, they had polymerization shrinkage, they had shorter clinical survivals, it was difficult to polish those, and also it was prone to water sorption and degradation. So next came what was Emax. So Emax has replaced the era of indirect composites and ceramics and partial bonded restorations. This article, it states that how Emax is better in its mechanical strength, long-term wear resistant, aesthetic longevity, and also in the fit or the adaptation of the Emax to the tooth structure. This is also an article which states how veneers which was made with Emax, it was lasted for about a decade. So the longevity has also been proven. These articles also states that the overall failure rate is very much less in Emax as compared to that of full coverage crowns. So considering all these articles and all these proven steps, Emax has been considered to be a gold standard for partial bonded restorations. Also, if you cannot isolate the tooth, you cannot do partial bonded restoration. First and the foremost important thing in partial bonded restoration is isolation. And obviously, when we are getting digital workflow, then why not? It is always better as compared to lab fabricated prosthesis. So we have heard so much about Emax. We know it has been gold standard. We have seen articles, but do you know what is Emax? So here are some SEM images of Emax versus the natural enamel versus the zirconia. And as you can see, Emax, it has a needle-like crystals which is surrounded in a glass matrix. This crystals, needle-like crystals, it provides structure and durability, and the glass matrix, it will provide optical properties, thereby giving an aesthetic result. So it is very much similar to the natural enamel when we considered it in the SCM image section. So you must have seen in your lab brochures and everything, there are two types of Emax CAD and Emax Press. So do you exactly know what is the difference between Emax CAD and Emax Press? So the difference lies in the crystallization process. So how it crystallizes, there actually the differences. In Emax CAD, we have two states of crystallization. One in which a lithium metasilicate is formed, and another in which final prosthesis, that is lithium disilicate, is formed. Okay, so there are two stages in Emax CAD for crystallization. And in Emax Press, we just have one state of crystallization. There everything is different, Baki, there is no difference in this. Okay, so in Emax CAD, two stages of crystallization occurs, while in Emax Press only one stage of crystallization occurs. So considering the tooth preparation guidelines, you have a case, but how do you prepare exactly for Emax? Let's get into this. So for various preparations, for inlays, onlays, we have different preparation guidelines. Let's consider to be an inlay. Suppose you have a class 2 carious lesion and you prepare a class 2 cavity as of an inlay. You just need to do 1.5 to 2 mm of the occlusal reduction, because that much bulk is required to give the strength to Emax. And also the cavity should be prepared with the rounded internal line angles, and the cavity should be divergent. Okay. Now, considering the tooth preparation guidelines in onlay usually there is intracoronal with including one or two cusp, right? So here, as you can see in this case, you have this cusp which is of very much less thickness as compared to these three cusps. These mesiopalatal cusp has very much less thickness. So we considered this cusp to be an undermined cusp. So we need to reduce this cusp, because this cusp does not has that sufficient strength to withtake the restoration forces, the occlusal forces. So we firstly block out the undercuts, and then we just reduce it 1.5 to 2 mm occlusally, the undermined cusp, and give a margin on the palatal and the mesial aspect, and this margin is supragingival. We do not touch the other three cusps. This is how you fabricate an onlay. So for crown lay, when you have a class 1 root canal opening, in such cases you can definitely go for crown lay. You just need to do an occlusal reduction of 1.5 to 2 mm, and you have a margin which can be shoulder or even heavy chamfer. If you don't give any heavy chamfer margin, then also it's okay. You just need to do occlusal reduction as you do in normal crown cases. And yes, pulpal retention, it is not mandatory in crown lay cases. You can skip this. You can just do a flat occlusal reduction. But if you feel that if by giving pulpal retention, you can give some extra strength, then you can give it, but this is not mandatory in crown lay cases. So just you need to do 1.5 to 2 mm occlusal reduction and you're good to go. So next, considering endocrown, here we need good amount of pulpal retention. Here pulpal retention is compulsory. It is mandatory to give pulpal retention in such cases, because usually endocrowns are given in cases where there is a shorter clinical height. So as you can see here, we have given usually the requirement of pulp chamber has to be 3 mm deep and 5 mm wide, and also the margin should have a circumferential rim of enamel. That is necessary. If you don't have any circumferential rim of enamel, the bonding will be compromised and ultimately you will lead into failure of your restorations. Now, you must all have known how to do a veneer preparation. So usually there are 4 types of veneer preparation. One is feather edge, where we just roughly reduce the labial surface. Another is window. We just reduce the labial surface, extended it till the incisal edge. We do not include the incisal edge. We just extend labially in the incisal edge. Next is the bud joint, where we reduce labially and also reduce incisally. We do incisal reduction in bud joint, but not in window preparation. We just do it in bud joint. So in window, we just reduce it labially, and bud joint, we reduce it labially as well as incisally. And in incisal overlap, we reduce labially, incisally, and also extend lingually. So these are the various measurements. You can take a screenshot or a photo depending upon how much shade change do you want. If your patient has a shade of A3 and you want to deliver A1, so you need to do some particular measurements or some particular reduction in tooth, especially in cervical, in middle, and in incisal area. And these are the specific measurements that will help you to give optimal results. As you can see here, this is the window preparation which is done. You can see I have not included the incisal edge. It is just the labial reduction that has been done. This is the incisal overlap. As you can see in the occlusal picture, you can see I have extended it lingually. So I have done labial reduction, incisal reduction, and lingual reduction also, and given a margin in the lingual half. So bond lay, you must have heard this is a fancy word, but there is no rocket science behind it. It is just veneer which has been prepared labially and onlay which has been prepared occlusion. So you need to do labial preparation and occlusal, one half of the occlusal preparation, and your onlay is ready. So as you can see here, I have reduced labially and just reduced this much. As you can see, I have just reduced the buccal cusp and given the margin near the central fossa. Okay, so this is how you prepare a onlay. So this is the heart of the presentation. That is our bonding protocol. How do you bond? You have prepared your Emax, inlay, onlay, whatever tabletop restorations you have. And how do you bond this is very much important, because if you go wrong in this step, you have messed it up around. First and foremost is when you get your inlay, you do your trying. Why that trying is done? To check the fit, your margins, your contacts, your shades. But do not tell the patient to bite in this case. You do not, because the Emax is not bonded. So you do not tell the patient to bite during the time of trying. Okay, you have to tell the patient to bite once you have bonded the Emax to the tooth structure. Then you have 2 phases. First is you need to prepare the restoration surface, and second is you need to prepare the tooth surface. So let's see how do you prepare your restoration surface. So the intaglio surface of your partial bonded restoration has to be first prepared with HF, that is hydrofluoric acid. If you're using 5%, do it for 20 seconds. If you're using 9%, do it for 15 seconds. Once that is done, just rinse and dry. Then you have to use your etchant, that is 37% phosphoric acid, for the period of 15 to 20 seconds. Again, rinse and dry. And then you can use a silane coupling agent. Remember, once you use a silane coupling agent, cover it with something, a bowl, a rubber bowl or something. You need to just cover your partial bonded restoration, and do not rinse in this stage and do not cure in this stage. Remember, you do not need to cure your silane coupling agent. If you do not have silane coupling agent, then what you can do? You can use a 7th generation or 8th generation bonding agent or a universal bonding agent. You just need to scrub your bonding agent on the intaglio surface for about a period of 20 seconds. Do not rinse it.
नहीं अगर मेरा होता है तो मैं हाँ नहीं मैं निकल जाती पर कोई कोई था ना पीछे
चले गए
हाँ आप यहीं रुक गए हैं
Do not rinse it
नहीं मैं
and
सिर्फ
just
बता
air dry it. Okay. So again, I'll be revising it. So for the restoration surface preparation, prepare with hydrofluoric acid, followed by your etchant, followed by your silane coupling agent. If you do not have silane coupling agent, do not worry. You can do it with your universal bonding agent. But do not cure your bonding agent or your silane coupling agent. Now, the tooth surface preparation. What you have to do on tooth surface, you just need to do your etching, that is with 37% phosphoric acid for the period of 15 to 20 seconds, followed by scrubbing your bonding agent for the period of 20 seconds. Again, do not light cure your bonding agent on the tooth surface. Now, once this both your restoration and your tooth surface is ready, now you can use or cement, you can use a resin cement or do your cementation process, which you can which it can be done with a 3M U200 or 3M Relix Ultimate or even 3M Relix Veneer or even Videolink by Ivoclar. So you mix this dual cure or light cure resin cement. You have applied on the partial bonded restoration. You load that partial bonded restoration on the tooth surface, and then you do a tack cure for 2 to 3 seconds. Then remove all the excess and floss the interproximal areas. This is very important because once you bond it entirely, then it is very difficult to remove your interproximal excess. And then apply a gel. You can apply glycerin or KY jelly so that it forms an oxygen inhibition layers so that it does not hamper the polymerization process. And then you can remove your excess and do a final cure by doing it for 20 to 40 seconds on each side. And still, if you have any excess, you can remove with some 12 number blade. Finishing and polishing can be done with any fine grit diamond burr, like any fine grit like yellow diamond burr would be fine, or you can also use any rubber polishers or enhance from Dentsply if you want. And then now, once this bonding is done, you can check your occlusion and reduce the high points. But do not do it at the time of trying because Emax itself is very brittle. But once it is bonded to the tooth structure, it gains the strength because it becomes a unit, single unit. So I'm a Gujarati, and I just want to share a message that if you can earn more money by doing less work, as we do in partial bonded restoration, we get, like if you want to prepare a crown, we have to spend 15-20 minutes to prepare a crown. And for partial bonded restoration, 5 minutes and you're good to go. So if you can work less and earn more money, then why not? You should obviously go, and obviously you are providing good quality and good care to the patient, and you are providing a material which has a superior quality and superior results. So yes, this is my Instagram handle. This was all about partial bonded restoration. You can reach out to me if you have any doubt, any queries regarding any cases. Thank you.
Thanks, Dr. Uruj, for sharing your knowledge regarding partial bonded restoration. From our distinguished audience, anybody want to ask any question, they can put the question in front of Dr. Uruj, and she might be solving your query related to the restoration. So there is no question, Dr. Uruj. Thanks for
Okay, sir.
joining us and with a very
Hello,
enriching
hello.
presentation. Yeah, Dr. Sanjay, you are audible.
Ma'am, can I ask a question? What is the difference between a crown lay and endo crown?
Acha, Dr.
So
Saurav is asking, yeah.
yeah, so basically, sir, crown lay is a tabletop restoration, what we say. So we just do a flat occlusal reduction. I had shown while in. I'll just show you the case, so you will get a better idea. Just a second. Yes, so this is the crown lay. Here, the similarity is very much in both, but what we do is just the occlusal reduction. We do not do any circumferential margin in this. We just go for occlusal reduction, and while in endo crown, we build this structure. You can see this structure. This has been built with the help of composite restoration with a packable composite, and this is the circumferential enamel which was already present. This was a healthy tooth structure, but internally it was not good, so I had to build this and give a pulpal retention there. So especially when there is short clinical height and you want to restore that tooth, then you should go for endo crown, because it will give more strength to the tooth structure. And especially when there is a more amount of carious tooth structure that is present, then you should opt for endo crown. But when you have class 1 carious lesion where just there is a caries from the occlusal surface, you can go for crown lay or tabletop restoration, where just you need to do any occlusal reduction.
Okay, ma'am. Thank you.
Yeah, thank you.
Any more questions from anybody? Yeah, Dr. Uruj, with your permission, we are moving to our next speaker. So
Yes,
that
sir.
we
Thank you
would
so
be
much for
on time
providing me
actually.
this
Yes,
opportunity.
yes, yes.
Yeah.
You can stay with us. Maybe if there are any questions arises for
Yeah,
this
sure, sir.
question and all, we'll come back to you. So you
Sure,
can
sir.
just keep your microphone in mute state. That's it. Yes.
Yeah, thank you.
So we have our next speaker, Dr. Sanjay Jain. He would be joining from Pune. Dr. Sanjay, yes, he has just shared his slide. So meanwhile, I'm just giving her his brief introduction. Dr. Sanjay Jain is an accomplished dentist with a remarkable career. He obtained his BDS and MDS degree from SDM Dental College, Dharwad. Achieving the 7th rank in Karnataka for BDS, he received the Dr. Ratan H. Memorial Award for Best Young Dentist, member under 30 years of age from Indian Dental Association India in 2004-5.
Oh, yes.
Dr. Jain has a wealth of publications. I'm just requesting my other audience to keep their microphone in a mute state so that it's not hindering our speakers and the attention our audience. So back to the introduction of Dr. Sanjay. Dr. Sanjay has a wealth of publication, including winning the Best Scientific Paper Award at the Indian Society of Periodontology annual conference in 2004 with over 23 years of experience. He specializes in perio implant laser practice and serves as a consultant at KEM Hospital, Pune. He is a faculty member of Bio Horizons Implant Program and the Society of Oral Laser Applications in India. Dr. Jain has delivered lectures and hands-on courses internationally and holds the distinction of being India's first master trainer for real-time dynamic surgical navigations for implants. He was also the only Indian invited to deliver the main podium guest lecture at the first Asian Pacific Division of the World Federation for Laser Dentistry Conference in Beijing in November 2019. He is a key opinion leader for DNS consensus meet in Rome, which is happened in 2023. Only Indian till date to win the best poster second award in the World Digital Dental Congress held at Morocco in 2023. Only Indian to win third prize at talent search competition at the Global Oral Reconstruction Foundation Congress at Bangkok in 2024. So Dr. Sanjay's presence in an international arena. He is a regular presenter in the international conferences and all. And so he's bringing say global experience here with our participants and all. Over to you, Dr. Sanjay. If I have missed any important point in your introduction, you can reintroduce
No, it's
yourself
been
so that our audience would understand you
no,
well.
absolutely. Thank you so much for that kind introduction, Dr. Narul Anwar. And in fact, I feel really privileged to be a part of this Digital Dental Congress, and I look forward to interacting with the audience in the next 45 minutes to 1 hour. And my topic today, I'm going to talk to you about what's the most happening thing in medicine across the globe. Let's not just talk about dentistry, but when we talk about artificial intelligence, it's happening every phase of our life, in be it e-commerce, be it medicine, be it dentistry, or be it for that matter, IT. So how does AI play a role along with this real-time dynamic navigation? And I'm going to throw light on few cases of dynamic navigation and how it does help us. Okay. Um, let's go to the presentation part. So what I'm going to talk to you about is what is the future of implant dentistry. I believe a lot of us are shifted towards from freehand to guided. And now guided, we are at the stage of semi-robotic. And the day is not far when we'll have a lot of robotic dentistry coming into dentistry and especially in implant practice. So where all does the AI come into picture? When we talk about artificial intelligence, let's understand it's not just the data acquisition. That means not only the cone beam computer tomography, intraoral scans, radiographs. It also has a lot of role in enhancing the imaging interpretation. So areas where you can't detect cavities, where you can't detect caries can be detected very clearly with AI. Areas where you do not have the density of bone, that very sound, AI can detect it before your naked eye can look at it. And the early detection of pathologies, which again is a boon in a lot of other oral and maxillofacial surgical procedures. The second role AI comes is in the treatment. So one is in the investigations part, the diagnosis part. Second, AI comes into picture is in the treatment planning. For example, a patient age 50 years of old walks into a practice with comorbidities like uncontrolled diabetes and all. And then you cannot just follow a standard treatment protocol that we have for all other patients. So in that case, we need to be more concerned about taking care of his inflammation, plaque control, and if you want to plan his implants, you need to check how his HbA1c reports are. So these personal treatment plans, AI plays a big role in it. It also does in outcomes of different treatment options that we have for our patients. And most important, before you actually start with these AI softwares, you can actually simulate, you can plan, and you can in fact show them with CBCT segmentation how well their implants can be placed, how their prosthesis is going to come. So it's like before you actually look into the before you actually start working to the patient's mouth, you can actually show them how the end result would be with some kind of variation sometimes. The third part that AI plays a role in implant dentistry is in the surgical phase. And that's where my core topic today is going to be. And that's where I'm going to enlighten you more on how this dynamic navigation helps. One, as I said, robotic and semi-robotic surgeries. Second is we have got these VR glasses these days. And in the screen, in fact, you can plan it out everything 3D. And you can incorporate that virtual planning and into augmented reality, doing the clinical cases at the same time. So this is the wonderful apparatus or the machine that I have in my practice. And This is the one I had it in 2017, and the company recently launched in 2024 in this Evo. So these both are dynamic navigation systems from a company known as Navident from Canada. What we have to see here is it has two stereoscopic cameras. Okay, let me get into the details of it. So these two stereoscopic cameras that you see here, that's where the role is majorly of dynamic navigation. That's how these stereoscopic cameras capture the black and white checkerboard markers that are there on our instruments and on the patient's face. Now, these two black and white checkerboard markers are recognized by these stereoscopic cameras, and a triad is maintained. What happens? How does this real-time navigation work? Is as simple as how you book your Uber, Ola, or Rapido. You take out your mobile phone, you dial the destination that you want to go. A guy nearby, the taxi fellow, notices it. He gets a notice. He gets a notification from the software that so and so person is waiting and he wants to take a ride there, and he opts for it. Then you know from where is the taxi guy coming, and both of you know the journey ahead, how to go about it. The same way dynamic navigation works. So the stereoscopic cameras are linked to 4 satellites. And what it does with this black and white checkerboard marker, they are very simple armamentarium which can be attached to an handpiece. In my case, in navigation, Navident, any handpiece can be attached. You can make the patient wear a nice, head tracker, and that has again a black and white checkerboard marker. So these black and white checkerboard markers are recognized by these two stereoscopic cameras. So this is basically forming a triad, and that's when whatever treatment plan that you have done for this patient on the software of navigation, that's Navident software, every drill that is calibrated, that is recognized, will be seen on the screen. So you don't have to actually look into the patient's mouth. And let me tell you, this does not involve any kind of radiation. It involves only the stereoscopic camera and the pre-feeded CBCT data. You can also have an intraoral scan so that you can map it up, but having a CBCT data is mandatory. So basically in 2003, this first vision-based optical tracking system was invented, and this uses the vision in real time to detect and track specially marked objects. So how does this work? Like I said, you need a data. CBCT is a must. If you have an intraoral scan, it's good. You can merge both the data. And then you just need to have a reference point, and that is known as registration. So those reference point can be patient's teeth, FPD, or an existing implant, or any anatomical area which is sound, which is not mobile, and which is firm. That can be incorporated as a registration point. You register them, and then it's like you have called like an Uber guy to pick you up, but if you forget your phone at your home and you walk down, the Uber guy won't recognize you because it's your phone which is getting connected. So same way, you need to have a fixed reference point in the patient's jaw where you're working, either the maxillary or the mandibular, and that has to be recognized by the stereoscopic cameras. So that's how it's going to be. And then every handpiece, every drill that goes in the patient's mouth, you just have to calibrate, which takes hardly a few seconds. Trust me, not minutes, few seconds. And the moment you try and place the drill in the patient's mouth, you can see on the screen where exactly it's going. So this is how you see a 3-dimensional view. That's why it has got a 3D view where you can see in real time. You can see in real time orthopentagonal view. You can see a cross-sectional view. You can see a tangential view. You can see an axial view. All this at one given point of time helps you in placing your implant in the most precise prosthetically driven position. And that's where the key is. The advantage here is you don't need any stents. You don't need any kind of additional armamentarium that has to be manufactured by a third party or from a lab. So you save on the cost there. Plus, you can do your modifications in the real time that I'll explain to you later on. So what is the first step? First step is planning. So you get data from the patient. That's a DICOM data. It's a CBCT and the photographs. So you click some photograph like this elderly lady walked into my practice with almost all teeth with grade 2 to grade 3 mobile. You look at that palatal photograph, the molars had no at gingiva there. She had terrible bone loss happening there, and that's how the radiograph OPG looks like. Except for 1 or 2 teeth, almost all the teeth were indicated for extraction. We made a scan. We made a planning of how this fast and fixed or all on 4K should go about. We could have thought about all on 6 or all on 8, but unfortunately, we didn't have enough of bone in the posterior segment, and the patient was not keen on any kind of additional sinus lift procedures. So this is what I'm talking to you. So I took patients' intraoral scan, and along with the patient's DICOM data, I merged both of them. So when you merge both of them, you can actually see on the screen the soft tissue thickness. Now, what does this help us? This helps us in determining the length of abutment that you need. So everything is pre-decided. So you can plan this out, have everything at your practice, and then go ahead and do it. So this is how I have basically merged both the data. And then next, as I said, it's a registration. So what we have to register is any 4 fixed reference point in the patient's jaw. Either you can register with the DICOM data or with your STL data, that's your intraoral scan. And preferably try and locate areas for registration which are having a tripod effect. So if you are doing an implant in the maxillary first premolar area on the right side, take a tooth behind, like first molar or second molar, take a tooth in the anterior, and take a tooth on the second quadrant. So if you have a triad, then the merging and the recognition of the data for registration becomes much easier. So that's how registration happens. You see this? It's very simple. It's a tracing tool. I'm tracing patient's tooth number, and that's where you get a score on the CBCT about you need to achieve a score of 100. So that we do it for 3 to 4 anatomical areas. It can be a tooth, it can be an implant, it can be an FPD. Make sure it's not mobile. If it's a mobile tooth and if it's you want to use that as for registration, then splint the tooth and then go ahead. Next comes calibration. So this is a calibrator tool on which you can calibrate a piezo surgical handpiece, endo handpieces, air rotors, micromotors, implant motors. You can also calibrate on this certain endo broken file ritual instruments. And not only the handpiece, but you can also calibrate on the same device your bird tips. So these are the different indications, flexibility that I was talking to about: piezo, ultrasonic, osteosome, straight handpiece, ultrasonic speed handpieces, 20:1 handpieces. So all this can be done. This is how I calibrate my tip. This is the fancy headgear that I was telling you we make our patients wear, like you see in this photograph where I'm doing a training program in my practice, where the patient is wearing a cool headgear which has got black and white checkerboard markers. My handpiece has one, and my 2 stereoscopic cameras recognize that, and we go ahead and place those implants. Now, once you do that, you need to track. So how do we do this? So this case, let's see this case which I've discussed with you earlier, the elderly lady who came into my practice. We extracted all her teeth. Since I do a lot of laser dental practice, I prefer decontaminating the sockets with a laser, diode laser. And that's where my 4 areas, the areas that you see in yellow marked are the planned implant positions. And you see on the upper right quadrant, tooth number 17, and then I have taken tooth number 13, 23, and 26. So these are the 4 fixed reference points, and I'm not going to remove this teeth till the time I place my implants, or if I register them well, I might take them out before we start placing the all on 4. So this is how the dynamic placement with navigation, implant placement with dynamic navigation happens. What you see in the red is where my implant has actually been gone on this bullseye screen that you see in the center. So in the end, I am 0.3 millimeters. How much? 0.3 millimeters from my desired point of entry. How much is my angulation error? 0.2 degrees. So if I've chosen a 4 millimeter into 35 degree multi-unit abutment, it's not just going to precisely fit in there. I don't have to change my angulations. and the depth I need to go more is around 9.5 millimeters. So three-dimensionally, you can see the point of entry, your angulation, and exactly the apex. So that's how we go ahead, Silip. So this you see on the screen is the presence of a tooth, but in reality, since this is a DICOM data on which I'm working on, these tooth have been extracted before I went ahead and placed my implants. So we went ahead and you see a different, this is the final post-operative OPG. So look at it. I have just managed very nicely to perforate the sinus. So sinus is absolutely safe, intact. My implants are in the desired location. The AP distance is well covered, and I could go ahead and do immediate prosthesis. How do we do that? So now what I've done is I did a detailed mock-up of the same patient. We impose this on the implant. We send this STL file to the lab, and lab gave me a provisional temporaries. And these temporaries were already there in my practice on my table before I actually took the patient inside the chair, on the chair. So once these are ready, what did I do? I fabricated them from the lab. All I had to do was make those access holes a little more wider because there is some kind of variation that happens. Might be 0.2 to 3 degrees, sometimes 2 to 4 degrees. And that's where I tend to make those access holes a little wider so that my fit is passive, and then I use a Q resin to pick that up. So you see this in the patient's mouth, we did that. We went ahead from here to here. And this was day 1. Patient walked in at 9:30. We finished placing implants by 12, 11:30, 12. We went ahead. We had the prosthesis with us. We had to do minor occlusal adjustments. We had to do minor fit adjustments. And patient walked out of the practice at 3 o'clock the same day with teeth in mouth. 4 months later, we went ahead with analog impressions. Nowadays, I do photogrammetry. So I pick them up on my Navident software. And that's it. We go ahead. This is the kind of prosthesis we give to our patients after 4 months. So from here to here is what we achieved. Now let's look at one video about how did we go about the same patient, and you'll understand the proper steps. So first is planning of all-on-4 implants. And then, as I said, we register 4 teeth. So these are the 4 teeth I registered. So this means patient's jaw is registered. So this is how we are going ahead. So we merge the surface scan with DICOM data. Mark any 3 points. Mark any 3 points. And your data is merged. Then you can just move around the cursor, see if the soft tissue is as per what you see clinically. Go ahead, merge the data. And then for lab, I also scan the lower jaw so that my JR is done, so that my prosthesis already has a predetermined height. And accordingly, we go ahead, we make the bite registration also done. So everything is done digitally. And how does this come into picture? Because of our AI-based technology in our software, which help us in achieving this quite predictability time and again, time and again. So it's not just one-off case that I'm discussing with you. We have been having this workflow at our practice since last 3 years now. In fact, going a step further with photogrammetry, we just do, after the implants are placed, we just scan them and we know the implant positions. The lab already has the STL data before. Digital mockup is done before. It's 3D printed and we give them the same day. And this is how we are checking for the accuracy, and this is in the real time. So what you see here is also the handpiece. So you know how much of angulation error I need to improvise on this. Now you see angulation error here. because these are implants which are going in a tilt position. So they are going to have a multi-unit angulated abutments. And this is precisely done the same time when the teeth are extracted. So you can imagine going into the socket where the tooth has been extracted in the precise desired location, which is prosthetically driven, is so very, very important. So you go ahead, you place your implants, and at every given point of time, everything is recorded. You can see how much of errors you have been making and how much correction can be done. So every time you take a new drill, the computer pops up, it says drill tip calibration, calibrate the drill, go ahead and place it. So we will go a little ahead. So this is how we went ahead. We placed 4 implants in Surek Agarwal's case, and that's how we achieved all the 4 implants were done with the help of dynamic navigation. And that you saw in the post-op radiograph, how beautifully we could get the perfect angulation and the prosthesis fit. Now let's look at this case wherein we went ahead and placed implants in a patient with a missing tooth 7. Now, why I'm discussing this case is it's a very high profile case, comes from another city, Bombay, to my practice. It's a very well-known attorney, works with the government of India in a very high post. A lot of people weren't keen on treating him. So then when he heard that I do navigation, he walked into my practice. He said, I heard you do something with computer, something with satellite based. So I just explained to him the concept of what dynamic navigation works. So that's how we first planned the prosthesis. I planned the crown. Then I decided what implant I have to do, selected the implant. And here, this is an open-end system. You do not have to follow one particular implant company. Any implant diameter, any implant length can be incorporated into this. Okay. So that's how I calibrated his teeth. Going little ahead. So we got the accuracy. That's how we did the flapless site ready. After the flapless site was ready, we went ahead, we did sinus lift. And that's what I want to show you, how we went ahead and did a sinus lift in this case. We went ahead, placed, these are the drills with Densa burrs. So here I've lifted the sinus. So you see, when I go beyond the red, beyond the planning, that means the sinus has been lifted. So we went ahead, lifted the sinus with osteodensification burrs. And the one advice I would like to give to all our young listeners, all our seasoned practitioners, please start investing in osteodensification burrs, the ones that are made by Densa osteodensification company, the Densa burrs. They will improve your implant practice to another level. The kind of sinus lifts indirect I do with these. In fact, it's been few years I've really not done a direct sinus lift now. Although I've been trained extensively in direct sinus lifts, but these days I'm so comfortable with my dynamic navigation and with the Densa burrs that we go ahead and see this is the sinus lift achieved. You can see that nice strengthened membrane. We lifted the sinus with no bone putty, and then we went ahead and placed an implant. So you see this, the implant has been placed, subcrustal placement. This is post-op RVG. We waited for 4 months. This is how good the healing comes. Look at the prosthetic position. Now, this is a tooth number 7. Getting the prosthetic position right is so very, very important. So earlier, what was 5.35 millimeters, after the sinus lift, we could achieve 10.14 millimeter. That's with indirect sinus lift and implant placement. Now let's look at another interesting case. A patient walks into my practice. He has anterior tooth, which has got a palatal resorption happening. We extracted, we did grafting first. So this is graft. We gave him Maryland prosthesis since it's an anterior tooth. Now, when we took a CBCT post-op, we realized that the width was too less. And we know many times in such smaller, such narrower width, perforation chances are very high. So we went ahead, we selected a 3 diameter implant with a longer length, but we made sure that we will not perforate with the help of our dynamic navigation. So you see my palatal going in the precise location. We went ahead, placed the implant. That's the 3 by 14 millimeter implant. We went ahead, placed that implant in, and went ahead, did immediate scan, and we went ahead and gave the prosthesis. And the interesting case, patient walks into a practice from abroad, and he has got this teeth refitted there. They are all broken. So all we did was we extracted one of those teeth. In fact, we advised him to go for other teeth rehab, but since he was in a hurry, we went ahead. Now I'm showing you this is the case where we went ahead and did anterior immediate prosthesis placement, and we could achieve stability. The initial torque we got was almost 60 Newton centimeter. So that's how we did some graft and membrane sutured. After we took an impression, that time I was doing a lot of analog. So this is by HHP attachment, and that's how we went ahead and did this. Now cases like this, 1/6 grossly decayed. I'm sorry. Okay, let's go through this. So patient walks in, we split the tooth, a traumatic extraction. I preserved the interseptal bone, and that's where the key is. Then along with dynamic navigation, we went ahead, we lifted the sinus up, indirect sinus lift, along with implant placement. So this is the osteodensification with indirect sinus lift there, and that's a 5 by 10 millimeter implant in place with a healing abutment, peak healing abutment. See this, we got a torque of more than 45 Newton centimeter torque, healing abutment placed. We sutured it up, came back after some time, and gave him a sound prosthesis, which is again prosthetically driven. So this is implant I did with 6. Why I'm showing you this case is here with the help of navigation, we harvested autogenous bone from the tuberosity area, the amount we needed exactly. So if you look at it, 7 had a defect, 8, the tuberosity had good bone. I'm not talking about the quality of bone, but the quantity of bone. So what we did, with the help of dynamic navigation, we scooped the amount of bone that we needed, and we placed it exactly in the place of 7 mesial, where there was inadequate bone. So we did simultaneous grafting, autogenous grafting with implant placement. So this is the pilot drill, this is the implant placement. We went ahead, placed the implant. You see so much of defect on the mesial aspect that you see on the scan also. So this is the healing abutment placed, grafted it, sutures given, and then post-operative radiograph. So all this is grafted bone on the mesial. Look at that gingival tissue I have around the implant. And we went ahead and gave a prosthesis to the patient. So let's look, one of the last cases that I'm going to share here is about the pterygoid implants. These implants are actually a real challenge for any seasoned practitioner. Initially, I was quite hesitant to start with. I know there are people who do extensive pterygoid and zygomas. I have a very dear friend, Rahul, in Mumbai, who does a lot of zygomas. So it's up to skill-based. Pterygoids are something which you need to be really careful as far as the anatomical zone is concerned. And that's where dynamic navigation plays an important role. So why did I choose so many points here for registration? Is because I didn't have anything posterior to the pterygoid. So to get a score of 1, that means it's the most precise and the most desired location. So I selected that, and then we started tracing the teeth. So you look here, we traced almost 9 teeth in the patient's jaw, maxillary jaw, to get that precise placement of our implant, because pterygoid is a zone which is to be respected as far as the pterygoid plexus is concerned. And most important, we need to have the implant in the proper cortical plate. What does that mean is the primary stability we should get with a pterygoid is the key for success of a pterygoid, and plus the placement of that implant. So this is how we are going ahead and placing our pterygoid implants. You see that we went ahead, placed that implant in, and you see this is how all happening in real time that you can see on the screen. So we went ahead, placed the implants in, and what you see here is a slight deviation that happened because the moment you go posterior, your handpiece tends to have obstruction from the palate and from the maxillary zone. So that's why you could see some amount of variation there. But if you look at the OPG view, our implant is in the perfect desired position. We went ahead, and this is the immediate IOPA radiograph that we took in this case, and we got perfect stability, went ahead and gave a prosthesis to this patient after 3 months. So I could have loaded this immediately, but I would just wanted to wait, because if you look at the existing teeth, we were contemplating, should we extract the other maxillary teeth and make a full prosthesis? But since patient wasn't keen at that point of time, we went ahead with this. I would like to tell you one thing very honestly is all these latest gadgets, all this latest digital dentistry that's happening is a boon to a practitioner, to academician. But if our basics are not strong, and if we do not really understand the technology per se, if we do not understand the proper usage of this, even these technologies won't help you anyway. What does that mean? It means with dynamic navigation, with AI, with semi-robotic and robotic, although you may achieve great success, there is a steep learning curve. To get to that success, my honest request to all our fellow audience, to the young budding dentists, and to all the people who want to get digital into their practice is, please have a sound knowledge of basic analog dentistry. That's how it's going to help. Understand how the technology can help you achieve that to a larger extent. And most importantly, is what you need to do here is to make sure that you incorporate these on a day-to-day basis. How does that help? Having an intraoral scanner in your practice and scanning every time you do a prosthesis or a restoration makes you much more adaptable to that, makes you much more versatile in difficult situations. Using one off day will really not make you a master in that. Same way with dynamic navigation. Although I have been doing a lot of implants since almost 2.5 decades, it's not that dynamic navigation was the only way I could avoid perforating the sinus. We have done a lot of sinus lifts earlier also without perforating the sinus. But what this gives me is more precision, more accuracy, and it's more predictable. What works is these three go hand in hand in achieving a perfect success recipe for today's implantology. We do a lot of endodontic cases also with dynamic navigation, such as broken file retrieval. Periapical surgery is a big way where dynamic navigation plays a role. Then we also have calcified canals, and you won't believe, with dynamic navigation, the access hole for a calcified anterior tooth, especially that I've done few of them, I haven't done a molar as of now. It's like a ninja access cavity. It's so small that for that patient, you really don't need to go ahead and give a crown until the tooth is discolored too. If the tooth is not discolored, just go ahead, make the smallest access hole that you can, because you're going completely navigation guided procedure, real time, and you can see how beautifully you'll be able to preserve a lot of tooth structure around that zone. Since there is another 5 minutes, Dr. Anwar, can I go ahead and show some more case, please? I'd kept this as a standby, thinking that if I get some time, I would like to go ahead and do this. So this is a very interesting case. Now, this patient also had been to few practices. The major obstacle in this case was the maxillary anatomy. And if you look at the tooth, so this maxillary zone had a lot of septa in between. So we traced the teeth. We got a score of 100. Anesthetized. We did a flapless. So I'm calibrating my handpiece. So I'm going to go through each step now. After my handpiece is calibrated, I calibrated the osteodensification pilot drill, the Densa burst, and that's how I'm going in. Now, what you'll appreciate here is if you look at the anatomy of the maxillary sinus, it has got multiple septa as well as some zones where the density of bone was not that great. So it was almost more than a bird drop. The moment I placed my pilot drill, it felt like as if I have perforated the sinus, but that was not the case. They had some lacunae, I would say, in the sinus. Patient does not give me any history of any procedure done. So that's how we place 2 cone log implants. That's how with the healing abutments. And this is before and this is after. So we could get an amazing 3D position, prosthetically driven placement of 2 implants with indirect sinus lift. And we went ahead and did this. So these are the radiographs. You see this, they had not adequate bone for just an implant placement. So we went ahead, did a sinus lifts. That's how the tracing happens. I showed you the punch. That's how the implant placement is happening. Okay. And this is in the precise time. You see that? Bloodless. No sutures required, no antibiotics needed. All I did was indirect sinus lift, put the patient on analgesics, went ahead, placed 2 implants. And that's how precise implant positioning has happened with this. And most importantly, this point also needs to be emphasized on that it's painless for the dentist. It's very ergonomic. I don't have to keep bending into the patient's mouth, not have an indirect vision. All I have to do is look into the screen and once in a while look into intraorally to see whether you are able to coordinate what you see on the screen intraorally. So mind-eye coordination is really important. So I would say it's a triad. Mind, eye, and hand. All these 3 need to be coordinated. What has been taught to us in our dental schools is more of hand and eye coordination. So here you need to make sure that what you see, you are able to replicate in the patient's mouth at the same time. That's why I said it's a steep learning curve. Initially, it took me almost an hour to place an implant. These days with navigation, it takes me 7 minutes average for 1 implant placement. And all on 4, we finish within 45 minutes to 1 hour of the surgical time that we do in our with navigation. And then the process and all takes a little longer time. So this is the first implant. This is the second implant. You see that it was a very, very different type of maxillary anatomy. I saw sinus with the post-op. I'll just take 2 more minutes to show why dynamic navigation has a role better than static guides. I'm not saying that surgical guides are waste. In fact, I do a lot of them. I used to. Once this dynamic navigation came in, I switch over to more to dynamic navigation because in this, intraoperatively, I can change my implant position. What happens with a static guide is it's pre-planned. It comes, you just place it in the patient's mouth and you go on placing. But what happens if one of those sites where it's especially in an immediate implant case, you are at loss because suppose the buccal plate perforated while extracting the tooth, then you really can't use that site. So you need to change, but then you don't have the guide ready at that point of time. Then you fall back again on freehand dentistry and you may not go with the desired prosthetic position or the pre-planned prosthesis that you have, you won't be able to fit in at that point of time. So this is a science teacher. We had this auxiliary view. We did a CBCT planning. So this, we went ahead, we did 4 implants. Already shared 2 existing implants earlier done elsewhere. So we went ahead again. I merge all the time the intraoral scans so that I know the angulation. We did the trace ratio, got a score of 100 for each tooth so that we get a score of 1. We extracted the teeth. We calibrated the drills and we calibrated the drill tips. Went ahead, placed the implants. Now what you see here in yellow is in blue is the abutment. So in this software, Navident software, I can in fact pre-plan my abutment, the height, the angulation, what kind of abutment I would need. So everything is so foolproof that you just need to be prepared with these kind of prostheses at the time of surgery. Go ahead and place it and you're done. 1/6 done, 1/4 done. This is where. So earlier I wanted to do it with the canine, and then we realized that the buckle plate with the canine had perforated. So we switch over from 2-3 to 2-2, and then 2-2 to 2-1. That's when we went ahead and placed the implant in the side 2-1. We got initial torque of 45 Newton torque for all the 4 implants. A periodontist by heart, so I go ahead and make a little bit of bulk on the buccal tissue, soft tissue. So I go ahead and place a lot of membrane there. In most of my cases, that's where I do a flap procedure. If I don't need that, then I go ahead and do a flapless implant procedure. So this is 1/6, 1/4, 1/1, 2/1. So we went ahead, did immediate scans. This is how the prosthesis started. The lowers were a free hand, and that's how we gave. So this comes to end of my presentation. I have a lot of endo cases to be discussed, sometimes the full mouth cases that we do. This is how we went ahead, did all on 6 and gave prosthesis within the first 3 weeks. This is the final prosthesis I'm talking to you about. This is how the patient walked in. This is after, this OPG is after 6 months. So that's how we went ahead and placed the implants. So thank you so much for being there and for your patient listening. I know this must have gone over the head for some of them who are just into digital dentistry, but trust me, friends, we are still at the tip of the iceberg. Digital dentistry is growing in leaps and bounds. Personally, I have been to a few good international digital dental congresses, especially the one at Morocco, at Casablanca, where I got the second best paper award. And I realized the way the world is growing in leaps and bounds in digital dentistry. And it's time we all switch over, or it's time we all get into it and make the best use of it and not be left behind. Doesn't mean we are in a rat race, but we really need to do something better for our patients every day. We need to upgrade ourselves for the betterment of our patients. Thank you so much.
Thanks, Dr. Sanjay, for joining across Pune and very informative presentation slides. And you have shared a lot of things about talk about dynamic navigation, and there is a discuss a complicated pterygoid implant as a not
Yes,
easy, very complicated. So nowadays are changing where we have very high precision, accurate placement of implant and all. So
absolutely, Dr.
things are
Nugent.
world is changing very fast. You say that this digital dentistry is progressing leaps and bounds in across the
Absolutely,
globes and all, and India should also follow those trends and all, and hopefully our
absolutely,
young dentist and those who are coming to dental field, they would be adopting more this digital dentistry rather than conventional to do more precise and the complicated
absolutely.
cases and all. So anybody who want to ask any question, they can ask question. We have
Uh,
privilege that a
yeah,
very expert implantologist with us. So if anybody having any query, they can ask. Dr. Sanjay has already displayed his email ID and phone number as well. So anybody want
yes.
to have any issue, want to learn anything, they can connect with Dr. Sanjay for further information and all.
Dr. Nul,
Anybody want to ask? Huh?
I would
Yeah.
like to appreciate the efforts you and your team have taken. Really, this is an amazing platform for a lot of young dentists to learn.
Yes, sir.
And the topic that you have specifically chosen about digital dentistry is the most, I would say, apt topic today. And it's definitely the need of the hour for all our dentists, practicing students, educationists, academicians, all of them to learn the best from your platform. And I really appreciate you. Thank you so much.
Sanjay. Thanks, Dr. Sanjay. With your
Yes,
permission, we are moving to our next speaker, Dr.
yes,
Shaban Khan.
please.
Yeah.
Yeah.
So, Dr. Shaban, you are there. Could you please unmute yourself?
Yes, sir.
I'm just, Dr. Shaban, taking a say minute break. There is a prayer call is happening from my place. So sorry for the inconvenience. I'm just
Sure.
taking a 30 seconds or 1 minute break. By the time Dr. Sanjay, you can continue. You can share your experience. Meanwhile, I'm just connecting in another 30 seconds.
Dr. Sanjay.
Yes.
Yeah, Dr. Mahendra Patait here.
Hi, Mahendra. How are you? So
I'm
good
good.
to hear your voice. We were colleagues together in Nasik. Tell me.
I'm in the Nasik, yeah. I thought of just get connected with you and know what is
Thank you so much.
yeah, the way the delivery is amazing. I can say that amazing digital world is going in a rapid direction.
Absolutely,
Because
absolutely.
for the CBCT, I can see this Navident what Mani Krishnan has introduced to us and really
Yes.
worthwhile. But the way you have shown that the areas like pterygoid areas and zycoma implants, I mean, it's like it's at the fingertip. What you
Yeah,
have,
it's like a cakewalk. It's like a
yeah, yeah.
cakewalk. Once you do one or two of them, and then you are like so confident about zygomas and pterygoids, you actually don't. Zygomas, in fact, my friend Rahul in Bombay does flapless. In
Yes,
45 minutes to 1 hour, he walks in with quad zygomas and he's done. Although I take a little longer, but Mahendra, you're so right. Since you were the earlier ones into CBCT, and you have seen the amount of impact CBCT has done to dentistry.
yeah.
In fact, in last 2 decades, if you ask me what has really changed dentistry is the invention of CBCT and incorporating of CBCT into our daily practice.
Yes, Dr. Sanjay.
Change the way dentistry practices.
Yeah, I still remember that we plan with surgical guide and rely on something
Absolutely.
working. And this first, this is the real-time imaging where we can absolutely see the things. And you made it really simple that template of India is available and you draw the naksha of the India. That way it's going on
Correct.
very curiously. Thank you so much. It's
Absolutely.
really a great
Thank
appreciation
you.
by these committees
Mine.
also that these are taking the efforts and reaching a lot of people. So hopefully others are also getting these ideas and guidelines. Only thing is what Mike thought regarding this as far as this technology is concerned. Tracking is how much time practically tracking is taking care of, because I was in Taiwan, they are having initially, but it was taking a lot of time in tracking. So how
So
was the experience?
now with the newer upgrades in navigation, to very honest, Mahendra, it takes me less than 3 minutes for a full arch tracking. Less than 3 minutes. In fact,
Excellent.
30 seconds per tooth. If I say also 4 teeth takes 2 minutes, 1 more minute for the tracking of the handpiece, the pilot drill, and the tracker. As I said, it's not to boost about, but the fastest I've done a single implant in a maxillary premolar with dynamic navigation, although it was without any indirect sinus lift. It was just a simple implant placement, was exact 7.36 seconds, 7 minutes, 36 seconds
Super.
with navigation. But that doesn't mean we need to be fast. I just timed myself just to see how a simple case without any kind of a sinus lift or bone graft can be achieved flapless. So it took us exactly 7 minutes, 36 seconds. But nowadays with dynamic navigation, all on 4Ks, I don't take more than an hour.
Excellent. And one more thing is, how about your experience looking at the screen and working in the oral cavity?
That's what I said. That's the most difficult part, because throughout our teaching, we have been taught indirect view, direct view, and sometimes when teachers are not looking at us, we used to bend and also have a absolutely view. So that kind of it's been brain mapped into us. So that's where to unlearn that is the key. So first thing we need to do is unlearn that and be specific, spend more time. You see, initially, to be very honest, Mahendra, I bought this in 2017 till 2018 November. That's good 1.5 years. I had just done 12 cases. And that 12 cases took me more than an hour and a half for a one implant. That was because that coordination of mind, eye, and hand looking at the screen is really, really difficult. But once you practice, then it's absolutely amazing. Like nowadays, if somebody tells me do direct, in fact, I'm a little hesitant because I'm so habituated to look into the screen and doing it that it's much easier that way.
Yeah. So screen become the eyes actually,
Absolutely, screen. And now with augmented reality software glasses, I don't even have to look into screen.
Yes,
Everything
of
is in
course.
front of my eye.
Yeah.
I'm telling you, technology is growing leaps and bounds.
So it's a hand screen coordination rather than
Yes, absolutely.
hand eye coordination. Yeah.
Yeah,
The reflex is, we are getting the reflexes when we are practice, and
absolutely.
then we are through and all.
Yeah,
Yes,
excellent.
yeah.
This is about the virtual reality you has added. That is an excellent point. Next time, we would love
Yes.
to see that how the virtual reality will be getting.
I have a video of that, but it's not edited. So I said, let's not add that. That will take too much of a time. But thank
Okay.
you so much for the interaction we had with Dr. Mahendra Patel. We both have been colleagues in Nasik Dental College, and it's great to
Agreed.
catch up with a friend.
Yes,
Thank
yes.
you, Sanjay.
Yeah,
And
yeah.
thank you to the organizer.
Yeah.
Through this, we get
Yes,
connected in this
absolutely.
way.
Dr. Mahendra would be joining tomorrow
Very
and
true.
throwing some more light on the implant. Yeah.
Yes.
Yeah.
Yes,
So
absolutely. Looking
thanks,
forward to
Dr.
that, Dr. Patel.
Mahendra and Dr. Sanjay for joining.
Thank you.
So
Thank you.
now
Thank you,
we
sir.
have to, as an organizer, your talk is, I mean, so we are enjoying a lot, but being an organizer, I have to take care of the schedule as well. So with the permission of Dr. Sanjay and Dr. Mahendra, I am just moving to our next speaker. Our next speaker is, say, more a photographer than a dentist. So we have a, just there is a movie, The Three Idiots, where we have seen that engineering student have a passion to do photography and all, and he's not able to disclose his, parents about his, hobby and all. So ultimately, he followed his hobby, and then he get growth in that photography and all. So we have the one a dentist, one dental surgeon, rather a periodontist, who has say interest in photography, and he's not a general photograph, but his interest in photography led him to getting a lot of recognition and awards, and just I'm just giving you formal introduction so you would have idea that what Dr. Shaban achieved in his long career. He is MDS in periodontology and implantology. He has won a prize for his photography, Mahabal Maqbara, organized by ICOMOS and UNESCO members, and was displayed in Indian Habitat Center, New Delhi. Then Dr. Shaban's profile was featured in Indian Dental Association publication, and his photographic shots were published by Nat Geo Traveler, Nikon, and Nat Geo Arab magazine. Additionally, his photography was also appreciated and published in BBC. It's a great achievement, Dr. Shaban. Then, along with this, his photography are also published in various newspapers. He's executive committee members of various photography groups in India. He had been invited to judge. He was a jury in various competitions of art and photography in national conferences as well as the various social media groups. He is also invited as a guest speaker in various academics and dental colleges to take lectures on photography. Other than dental, he has a special interest in wildlife photography. Most of the photographers definitely have the interest in wildlife photography. So with this brief introduction, if I missed anything, Dr. Shawan, you can add on, and if you can have 2-3 minutes time, you can let us know how you get the interest in joining this photography and all. Over to you, Dr. Shaban. Yeah.
Yeah,
I have made you a co-host, so you can share your slide. Yeah.
thanks a lot, sir, for this introduction. So yeah, I would have a short like a short story that how I that started this photography journey. So it all started with from when I was in my schools, in my high schools, and at that time I was not having that big kind of DSLRs or any heavy lenses with me. So I was just having a 2 megapixel phone, and on every holiday, I along with my friends we used to. I live in a city in Gujarat, which is Gandhinagar. So, and the outskirts of that, there is a quite lots of forests and greeneries. So we used to roam around the forest and the jungles. At that time, I was not having a good camera. Later on, when I got admission in my BDS, in the first year itself, I bought my first DSLR. And from then onwards, from the second year, I get to know that there is a field in the dentistry that is known as dental photography. and I started searching about what is dental photography, what things are been required to get good pictures, and concluded everything and every setup by the end of my third year. Now the thing was, I was in dental college, and I have a good equipments with me. I used to approach my nearest clinic that I have these things, and I will just come observe and document your cases. So with that, I used to learn like how it actually works. So I had not attended any courses or any lectures, but it is kind of self-taught thing. And from my final year BDS, I used to, people calling me that they are having a good full large cases. So can you come and document? And in that time also, it's like started a consultation kind of thing. Like every in a week, I got 2 to 3 calls from the doctors that I have aesthetic case, I have all on 4, all on 6 case. So likewise, this journey have begun, and I would like to share that when I was in my final year BDS, I was invited in an academy to take a workshop on dental photography. So before taking much time, let's start that what is dental photography, right? So first, first of all, I would like to have a two-way communication with the participants. I would love to have to listen from the participants that why we should start dental photography, and even from the participant. Okay, all right. So we'll further move on. So from my point of view, there are main 3 reasons why you should start documenting your cases, right? So the first is self-improvement. You remember I told that I used to have a 2 megapixel camera. So this picture was clicked at back 2010, right? And at that time, I clicked this picture. I used to post that on the social media, on my Facebook timeline. This picture is still there. I used to get much compliments from my family friends कि भाई बहुत बढ़िया photo ली है. Even I used to wonder like so beautiful picture is a peacock is sitting on, and there are clouds in the background. There is a Christmas tree, right? But now in 2025, when I look at back that picture, I can see that there are no colors in that picture, right? So this is how your photography or documentation improves your work, right? Let's have an example of that in the dentistry. A patient came, a 65-year-old male patient came with a deep periodontal pockets, right? After we did scaling and root planing, so there was no reduction in the pocket. Then we go for the flap surgery. We raise a full mucoperiosteal flap. We did scaling from our naked eye. We were not able to see anything. Then we clicked the picture, and then we came to know there is still some calculus left over there, right? Then again we did scaling and root planing, and this is how the tooth surface start planing. Now, while clicking this picture, we got to know that there are still some granulation tissues left over there. How? By again clicking the picture. Now, after we degranulated, we again click the picture, and you can see that there is nicely root surface is plain, and there is a healthy alveolar bone, right? Another thing, when you're placing an implants, right, from your point of view, you won't be able to judge the angulation, right? So when you ask your any assistant or your assistant doctor to take a picture from a 6 o'clock position, you will get to know the better angulation of the implants. Okay. Along with that, the second important thing, which I feel important in importance of dental photography, is a success story. In today's era, जो दिखता है वो बिकता है, right? So a patient came with a smile like this, and we converted his smile like this. Okay, so how we converted this patient? So basically, we just shown the patients the patient we shown pictures of the whole procedure to the patient, right? So this is the case. We showed this case to our patient that this was the case, and even this condition is worse than yours. What we did, we take some pictures, then we hardly removed any tooth structure. And on the same day, we will give you provisional processes. Then this is how your processes are going to be made. And this is how your final processes will look like. And first we will check the fitting. And then now with the help of these pictures, we explain to the patient that we will apply a blue jelly in your teeth. So at the same time, we told to the patient that you might taste a little bit sour or something like that. Okay. So what happened is that whenever we inform the patient with the help of the pictures, so patient will be mentally prepared that now that blue jelly will be will be put on my teeth, and that might be sour in the taste. Next, this is we showed the patient that how their final processes will look like and the extraoral smells. So this was the second important use of a dental photograph. And then the third is that is your diagnosis and treatment planning. So how we converted that patient, we click extraoral and intraoral pictures. We import them in the softwares, and how we can judge the smile line of the patient, the shape of the tooth, and we can immediately show before and after, even before starting any procedures. So the conversion of the patient increases with the help of good documentation along with good softwares. There are n numbers of use of documentation like patient illustration, patient education, patient communication, co-diagnosis, digital presentation. Important thing is medical legal cases, and another important thing is marketing. And nowadays, I think all of you might have been faced that when you are posting pictures on social media, you require high definition pictures of your work. No doubt you had done an excellent partial bonded restoration or excellent implant you had placed, but you need to document that good thing, right? Now let's start about the basics of dental photography. So what is photography? Photography is an art, science, and practice of creating durable images by recording lights. So what we are doing in photography, we are recording lights electrically on the image sensor or chemically by film. That is, nowadays only digital cameras are being used. So photography is all about recording lights, right? So I'll be using this word in the next coming slides repeatedly, that photography is all about recording lights. So let's compare photography with the another common thing in our dentistry, that is radiography. So what happens in a radiograph? There is a source, there is a subject, and there is a sensor, right? So whenever the source is coming, it gets penetrated from our subject, and the data is been recorded on the sensor. Similarly, in photography, there are three things. There is a source, there is a subject, and there is a sensor. So source here is the light. In radiology, the source was X-rays. In photography, the source is light. Now, instead of penetrating, what happened? Light is getting reflected from the surface, and it is getting recorded on your sensor. That means your camera. Okay. So have a look at what is DSLR. So basically DSLR is of body and the lens, right? Now let's study how a DSLR works. So I had previously in previous slide we studied that there is a body and there is a lens. So what happens? A light source is coming, it is traveling from the lens, and here is the body of the camera. At the 45-degree, you can see there is a mirror located. Behind the mirror, there is your shutter, and behind your shutter, there is a sensor. Okay, so whenever you are pressing your shutter button, this mirror goes upwards, and the light travels from the lens through the shutter to your sensor. So this is the source of light. Light is coming, light is reflecting, and light is traveling to your camera. So what is photography? Photography, it's all about recording lights. And when it is get reflected, it travels to the lens, and then it is captured on your sensor. Now, nowadays, as the technology is getting advanced, so DSLRs are being slowly replaced with the mirrorless cameras. Now, what is mirrorless cameras? So, in mirrorless cameras, there is no mirror at the 45-degree angle as it is there in the DSLR. So, here the light directly travel from the lens to the shutter and reaching towards your sensor. Now, in the mirrorless cameras, you will be able to see everything digitally on your viewfinder. Here, what was happening? That light was coming, it was getting reflected at this mirror, then it was traveling through this pentaprism, and you were able to see everything optically in your viewfinder. That's the reason whenever you are clicking your shutter button, this mirror goes up, and you are not able. There is a blank screen, or there is a blank screen on your viewfinder, and that's how your image is getting recorded. In the mirrorless, there is no optical reflection. There is directly your light is getting recorded on the sensor. Now let's have a look. What is focal length? I think whoever from you are using DSLRs, you might be having it in hand, and you will be rotating a big ring. So that is your focal length. So focal length is basically zoom in and zoom out of your lens, right? So the more is the focal length, the more zoom you are getting. The less is the focal length, the less zoom you are getting. Now let's study what is exposure. Before that, I would again like to repeat what is photography. Photography, it's all about recording lights. So exposure. So exposure is the amount of light per unit area reaching your sensor. Okay. So it has been controlled with the help of your shutter speed, your lens aperture, and ISO. Okay. Along with that, if you are using any flash, then also you can control it with the intensity of your flash. So there are different types of exposures: overexposure, underexposure, and balanced exposure. So let's have an example of each and every one. So here is a picture of here is a example of an overexposed picture. Like in the background, there are clouds, but because it is overexposed, you are not able to differentiate, right? So in overexposed picture, you are not able to differentiate the white things. Okay. When we talk about underexposed picture, now you can see that there are clouds, but you can't see the details of the architecture. So in underexposed picture, you are not able to differentiate the black things. Now, what kind of picture we desire? That is a balanced exposed, in which we can able to differentiate white things as well as we can able to differentiate the black things, right? So let's have a comparison of all the three. So on your left hand side, there is an overexposed picture. On your right hand side, there is underexposed picture, and in the center, there is a balanced exposed picture. So how do we control this exposure? Basically with the shutter speed, the lens aperture, and the ISO. We will study all these three in detail in the coming slides. So as discussed earlier, we control the exposure with the help of aperture, shutter speed, and ISO. Now one by one, we'll study what is aperture, what is shutter speed, and what is ISO. So an aperture is basically a hole in the lens through which the light passes and reaches toward your sensor. Now, along with that, I'll show you some examples. So aperture is denoted as f-stop. As in this picture, you can see aperture at 1.4 and aperture at 16. So at 1.4, the opening of lens is quite wider, right, compared to f16. In f16, the opening of the lens is quite narrow. So more light will be reaching towards your sensor at f1.4 compared to f16, right? So when the number is small, the image is brighter. And when the number is on the bigger end, the image will be darker. Now, along with that, the aperture also controls the depth of field. Okay, so let's have an example. A picture clicked at aperture 1.8 and another picture clicked at an aperture 16. So on your left hand side of your screen, you will see that you will be having sharp central, lateral, and half part of your canine, rest all posterior teeth are blurred, right? On your right hand side at F16, you can see central, lateral premolars, molars, even the background texture is quite sharp. So the more the number, the more will be your depth of field, right? But picture will become quite dark. Okay. Now, second thing is your shutter speed. So here also shutter speed is denoted 1 by of a second. So 1 by 500 of a second, 1 by 2. So let's have an example. What is shutter speed? So basically there are two curtains. Okay. So first curtain is moving up, and the time duration after what the second curtains move. So in this example, you can see at 1 by 8,000 and at 1 by 1,000, see the gap between the two shutters, right? So at 1 by 1,000, more light will be traveling on your sensor compared to 1 by 8,000, right? So along with controlling the darkness and brightness of the picture, your shutter speed also freezes your subject. You can check in this example at 1 by 500, the person is freezed, right? And at 1 by 2, you can see there is a motion capture, which is called as a motion blur. Okay, so let's have another example. On your left hand side, a picture clicked at a shutter speed of 1 second. You can see the movement of the people in this 1 second. It has been recorded. Whereas on your right hand side, a picture clicked at 1 by 2500. You can see how freeze that moment is captured on your camera, right? So the more the number, right, the more darker will be your picture and more freeze you will be getting the picture. Now, the third thing, that is ISO. ISO is basically the sensitivity of your camera. The lower the number, the darker picture you will be getting. The higher the number, the brighter picture you will be getting. So these were the three main elements of photography: the aperture, shutter speed, and ISO, which controls your brightness as well as darkness of your picture. Well, let's have an example. A picture clicked at ISO 200 and another picture clicked at an ISO 3200. See the difference? How the number is increasing and how brighter you are getting the pictures. Now, exposure triangle. So exposure triangle is like we want to create a balanced exposed picture while changing all these three parameters, right? So before heading towards the flash, I would like to ask, I would like you all to note down the settings which I personally use in my practice. Is that whenever we talk about the aperture, so I usually don't keep my aperture value below 20. Like f-stop should not be less than 20 in the intraoral pictures. Your shutter speed should be in the range of 1 by 100 to 1 by 200. And third is your ISO. Your ISO should not be more than 400 for the dental photograph. So these are the ranges which I am telling. Depending on the situation, if you're getting darker or brighter images, you can change, but you should change the things within that limits only, right? Now let's have a discussion of different flashes. So basically there are ring flashes and twin flashes which are commonly used in the dental photography. So ring flash is a 1 point flash and twin flash is a dual point flash. You can see in this picture there is one ring flash. Okay, so only one light source is there, whereas in twin flash we are having two light sources, right? So along with we are getting few benefits, so that we can change the direction of the flashes in twin flash, whereas in ring flash we are not able to change the direction of the flash. So there are different powers of flashes. So at 1 by 1, your flash will be having maximum intensity of the light, and subsequently like 1 by 2, 1 by 4, 1 by 8, your power of flash will get decreases. Another thing what we can use is the soft boxes with the speed light. So the speed lights are mounted on the soft boxes with the help of this S bracket, right? Also, we can use studio lights. Now, another thing is retractors. So, which color retractor we should use? So, you should always use clear, transparent retractors instead of the colorful retractors, which will give some amount of light reflections and hue on your teeth. So, always and always use clear and transparent cheek retractors like this. Okay, so this is my personal favorite retractor. You can see there are handles on the sides. With the help of that handles, I can easily retract the cheek and lips, right? Now, another thing is the contraster. So contraster we used to place behind our subject and to get that black background. Now let's talk about what mirrors we should be using. So we should always use stainless steel mirrors. We should not use glass mirrors or any fiber mirrors. Why? Because they give us ghost reflection or ghost images. As you can see in glass or fiber mirrors, there are two times lights has been getting reflected and we are getting result with double images. So always use front coated or you can say stainless steel mirrors for your dental photography. Now some principles of dental photographies are there. First is retraction, second is isolation, and third is illumination. You should always use clear, transparent retractors to retract your lip and cheeks, or else you will be getting shadows on your site which you are going to document. Along with that, your site should be free from saliva as well as from the blood. So proper isolation should be there, and you should be having a light source, whether it is a ring light or it is a twin flash. Now, if you fail to get some amount of exposure, you can correct that in the post-processing softwares like Photoshop, Lightroom, Snapseed, which are freely available for on your Play Store. The things which we want, that is rotation, highlights, crop, and that all features are freely available on the Play Store, right? You don't need to pay for the premium for the things which we require for a dental photography. Now, I would like to give some takeaway points like from camera point as well as from the patient factor. So in the camera, as we discussed, three important things, that is the ISO, your aperture and your shutter speed, right? So ISO is your sensitivity. Then as you increases the number, your brightness will increase. Your aperture, as you increases your aperture number, the darkness of the picture is increases, but along with that you are getting a good amount of depth of field. Now if we talk about patient factors, so proper retractions with the help of retractors, proper isolation and proper illumination should be there, right? So here I'm sharing my Instagram ID as well as my mail and contact number. If you have any query, you can always reach out to me. So anyone is having any doubts?
Yeah, thanks, Dr. Shaban, for sharing your take on the photography in dentistry. Actually, it's very important to record keeping and all, and for taking the reference, etc. So anybody who want to learn, he or she can connect to Dr. Shaban. And anybody who want to ask any question here right away, they can ask. And Dr. Shaban has already given his contact detail, etc. So anybody who want to ask any question related to photography, because there are a handful of dental photographers who are available in India. So you have a better idea, how to take the photograph and all. And if you learn this skill, you can also help your other colleagues as well to taking a photo and keeping the records as well. So anybody want to ask any question, they can put the question on a chat box. And the rest thing is that with permission of Dr. Shaban, Shall we move on to the next speaker? And if you are stay with us, if any question comes, I'll come back to you, Dr. Shahbaz.
Sure. Thank you, sir. So, this is a great platform for every young dentist for learning everything about digital dentistry. It's seen all the topics, and it has completed everything in which this digital dentistry is going on. Thank you, sir.
Thanks. So we are moving to our next speaker, the stalwart, Dr. Ratin Das. Those who are in academics and in dentistry, Dr. Das do not require any introduction. But as a formality, as an organizer, I have to, do my duty to introduce him. Uh, he would be going to speak on digital dentistry, integrating technology across all specialty. Dr. Das, can you say hello?
Hi everyone.
Yeah, hi. Good to see you, sir, for a long time. Yes.
Thank you so much for
Yeah.
being as part of your conference always.
Yeah.
It was a
So,
pleasure.
with your permission, Dr. Das, I'm just, giving your brief introduction. I can't summarize your introduction in a words actually, but still, as an organizer, I have to, take the responsibility. Dr. R.D. Das is currently serves as a director of the Indian Academy of Aesthetic and Functional Rehabilitation, and he is a professor of practice at D.Y. Patil College of Dental Science, Nerul, Navi Mumbai. Dr. Das has made significant contributions to the field, conducting a specialized training program in aesthetic and functional rehabilitation. Dr. Das has honed his expertise through international training programs, including certification in aesthetic and functional rehabilitation and functional occlusion. He is currently the editor of Dental Dialogue, the official journal of IDA MSV. So, Dr. Das, if you want to add anything, the audience would love to listen you, and you are summarizing means how the role of digital dentistry in integrating technology across all dental specialty and all. Over to you, Dr. Das. You are audible.
So let me just share my
Yes.
presentation first. Should sound. Let me start my presentation first.
Yeah, it's visible.
I'll see my screen, right?
Yeah.
Thank you, Dr. Nurul, for the lovely
Thanks.
introduction. And it's always a pleasure to be part of this digital conference that you organize. I especially like your themes. Every year, you all come up with a wonderful theme. And now that dentistry has rotated so much around digital world, we have gone to the digital world of dentistry. It's so important to bring to our the newer generation should understand how dentistry has become digital. So with that, let me just start my presentation with a little introduction.
This is the future. Evolution. This is the future. Evolution.
How I would like to introduce how dentistry went right from, one character to another character. Nothing has changed. It is only the outlook that we have changed. So there are two words in dentistry, aesthetic dentistry and digital dentistry. Today we are all talking a lot about this. So what is aesthetic dentistry? Is it something different? If I go back to our dental college days, every definition of dentistry started with the term the art and science. What is art? Art is nothing but aesthetics. So dentistry has always been aesthetics. It's only that we want to sell something new to the newer generation. We are calling it aesthetic dentistry. Similarly, what is digital dentistry? Dentistry has always been digital. We have used our digits always. Are these not digits? So this is also digital dentistry. But technology has taken over these digits. So let's understand how technology has come in. Why technology has come in so massively. We all know the digital India today, with the newer government policies, how today every person is having a UPI ID, every person is using digital payment options. Today, basically digitization has given a complete game changer in the entire country. Why only into dentistry? So what is a typical, if I look at let me just remove this because it's a little obstructing, huh? Okay. So what is a typical dental visit? If we had, the patient comes, we took an OPD, we took an X-ray, we spoke to the patient, we did scaling, we did ortho. All of this integratedly, today digitization has touched every part of it. So let's see each of it one by one, how it has happened. So what will be dentistry henceforth? From this, where we did, today we're going to integrate technology across dentistry. So let's understand. The first department that we see our patient, if I see even in our clinics or in institutes, what is it? It is diagnosis and treatment planning. Has digitization come into it? Very much. There was time when we used to have case papers like this, where records were kept on a sheet of card or a paper. Today, no longer we do this. Today, everything has got digitized. Today, there is a software. We put all the information on that software. We have all the information of the treatment that is done by the patient onto that software. So, at a click of a button, at anywhere, wherever access to that software, I can see the patient record and I can preserve it with no space required. If you come to my clinic today, I have got 2 cupboards full of case papers. But post digitization, there's no need of any case paper. Everything is just digitized. Everything is just onto my laptop, onto the cloud. Everything is saved on the cloud, which I can access whenever I want. Appointments and instructions. There was a time when I used to have an appointment card like this. There was an instruction sheet which was given. Today, no longer we need to do all that. We just send an appointment by SMS or a WhatsApp. And instructions we send through what is called as a digital form. You don't have to print a paper, everything. So the patient at any moment of time, everybody 24/7 has a mobile on their hand. They have a mobile as close to their heart all the time. So the mobile will have the entire information. I'm showing you, this is how I share the entire information with my patients. You don't have to give any paper today. Radiology. There was a time when we were taking X-rays, we need to develop it, we have to rinse it, fix it, wash it, and then this plate would come. Today, with a click of a button, what happens? You can have the entire X-ray. Moment you click, immediately it can be visible. There is no time gap. Digitization has come into radiology so much that we don't realize that this is digital dentistry. Isn't it not digital dentistry? When we think of digital dentistry, we only think it is scanning. No, friends, digitization has come much before scanning into dentistry. See this? Click of a button and the X-ray is there. There. You can check it. You can send these images. You can take a consultant's opinion. You can see it, record it, see whether today, and minimal exposure because of digitization, minimal ease of keeping records. That's digitization. OPGs and CBCTs. There was a time when it was difficult to send a patient for OPG, CBCT. By the time the patient comes, by the time the report comes, it all, the click of a button, you send a patient, the OPG is done, the CBCT is done, and all the information is on your laptop at the click of a button. Everything is on your laptop. So whenever the patient wants to come, all I need to do is I go ahead, click Stellar, and I can see all the records of the patients of all the OPGs that is done. So how digitization has today helped us in preserving all this information, even in radiology, right? Again, at any moment in time, I can just open that patient's record. Even after a year, 2 years, 5 years, patient comes, the records are there with me, right? Photography, how beautifully Dr. Khan has just spoken about photography. Today, there was a time when we had to click a photograph, wait for that reel to develop. 36 photographs had to be clicked. The entire thing had to be developed. We were somewhere like this, where we were blinded when what is happening. Did we really take what we wanted? But today, because of digitization, Just a click of a button and you can see what you have done. You can rectify, you can modify. Today, how Dr. Khan has beautifully explained how we modify the photograph. We see, we feel the exposure is not. Yes, Wakar, but okay, thank you. I thought she has a query. So with a click of a button, we can see the photograph that we have taken. We can rectify it, correct it. That is how digitization has touched our photography, right? Then we come to, showing our patients. Just a click of a button, I have a camera, I can show my patients. Patients can see what are the problems. If you do that, an intraoral camera today is a boon. That digital tool has become a boon in our practice. You can just show your patient, showcase your patient everything at every moment, where there's a cavity, where he needs a scaling, where is the calculus, where is the problem. Everything can be explained and the patient can see it and immediately react to it, understand it, and get convinced to what you're trying to tell your patient. Conservative dentistry. Digitization has revolutionized our conservative dentistry. Earlier, there was a time when we would have to put a stain and see whether there are cavities, show it to the patient, explain to the patient. Today, we have just lights just expose it and the patient can see where there is a cavity. You can also have digital caries detection. You just have to go in with that probe. Today, Cavo Diagnodent is a wonderful tool. You pick up that tool, uses a fluorescent light, you just place it on the tooth and you can see where at what depth the cavity is. That is how digitization has helped conservative dentistry. Endodontics. There's a time when we had to take x-rays, multiple x-rays to see whether we have touched the pulp, what is the length of the pulp cavity, what is the length of the root canal, where is the pulp, how far is the apex. All that was just, imagination and radiology and all of it had to be done, measurements. Today, just there is a tool. We know we all have this apex locator. Is it not a digital tool? It's the most vital digital tool in our practice today. It has changed. It's a complete game changer. Because of our apex locator, we can feel, we can touch, we know when we are at the apex. That's how digitization has revolutionized endodontics. Periodontics. In periodontics, there's a time when we would have to, bone sound, see how much is where is the bone, what crown lengthening has to be done. But today, because of digitization, you can just take an X-ray, you can just take a scan, you can take their CBCT, fuse both of them, and you can have a stent, and you can be sure where you're going to have your CLP done, at what length you want to have your CLP done. Everything can be digitized. That is the boon of it. Biofilm technology. Today with the biofilm technology, you just spray it and you can see this biofilm and you can show it to the patient. Patient gets convinced and you can go ahead and do your treatment. In oral and maxillofacial surgery, has digitization come into it? Yes. These were conventional practice where we had to see what we are doing. We had to use illumination. We had to use loops to see whether what I'm doing. But today, because of digitization, everything is robotics. You can just feed the information and the robotic arms will help you to perform the complete surgery. That is how, again, digitization has helped in oral surgery. See this. You can even position your tool, everything. There's an optical tracker. This is a position marker, which will tell you where that robotic arm has to go, and the entire thing gets digitized. That's how digitization has made oral surgery more precise, more predictable, and more accurate. Orthodontics. I think the biggest game changer is orthodontics and digitization. There was a time when we had, we'll take a cast, do a tracing, show it to the patient, explain to the patient that this was your problem, all that, we show, and then the patient is not convinced. Somehow we convince the patient, we show him pre-op, post-op models. He feels that उसका हुआ, मेरा होगा क्या? ऐसा हो सकता है? ये तो डॉक्टर बोल रहा है. And even we were not sure what would be the final outcome, how the face would look, how the jaw would look, what would be the actual position. But today, friends, we know this. Then comes your implantology. In implantology, there was a time when we would have to take OPGs, X-rays to know where my implant is going to be placed. Yet, because it is all 2D, we did not know whether it is going to be perfect. Today, we have what is called as guided implants. You have a scan, you have everything guided, you have these positioners, the tool will go ahead, just like a surgical, it will help you to know exactly where your implant has to place. It is all pre-calculated, pre-designed, and everything goes accurately. It becomes so much more predictable. The game changer again of digitization was in prosthodontics and crown and bridge. How? In this faculty testing. From conventional, we came to what is called as digital prosthodontics today. Impressions. There's a time, I'm sure all of you all will remember how we took the Salchinid impressions and all those blunders that we did with our impressions. But today, you have a scanner. You pick up, scan, you show it to the patient. With a click of a button, the information is transferred to your laboratory. The lab personnel starts doing his work. It is so fast. That is how digitization today has touched. But word of caution, remember, I'll come to that a little more later also, that do not expect that just because you scan, you will be getting rid of all the impression problems. Remember, problems exist. We have to master our skills before we get into digitization. Okay, today in my clinic, this is a routine for last 10 years. We have been doing this. Click of a button, scan, take the impression, information goes to the lab prints a model and comes. I'll tell you how the scanning has helped my practice. I had this patient who was a mentally challenged patient. He would not be convinced he needed a lot of dental treatment. He needed endodontics, he needed surgery, he needed crown and bridge, but he would not sit on the dental chair because he was a young boy and he was mentally challenged. It was very difficult. So what we did, we took him in the OT, did all his endo, did all his oral surgery, did all his preps, scanned, everything done in just a couple of hours. Everything was done because of digitization. There is no fear. Earlier, when we had to take impressions in the OT, we would always feel scared. The patient will aspirate the material. How do I prevent the material from going in? Today, the scanning comes and we get our results. Jaw relations. There was a time when we had to do all these Facebook records. Today, jaw relation has become completely digitized.
Dr. Das, there is a background music in the videos, so we are not able to hear you what you are explaining in midway.
just with a click of a button, all this information from the scan can be coupled with your scan as well as whatever the digital articulator did. All that information can be loaded onto your analog articulator, or a digital articulator option is left to the practitioner. Shade. Shade has always been a challenge in dentistry. It's always been a challenge in our practice, how to get the right shade. We have done all stunts. And the biggest problem is we did digital stunts in it. How? We take a photograph and we share the information with the lab. Now, as Khan has exactly explained, what type of camera you're using. So here I would talk about mobiles. Basically, we dentists use mobiles. We just click a photograph on the mobile, send it to the lab. Now, just have a look. This is my dog. She's my pet here. I've taken photograph of my pet from 2 cameras, 2 mobiles at the same time in the same location. But look at the color difference. So sending a photograph is one of the worst way of transferring shade to your lab. So what ideally you should do? Today we have the digital way. And what a Vita Easy Shade tab is the best way to do it. What is it? It's a spectrographic machine where through a spectrographic machine, you can see completely the entire shade gets recorded. You have both the options in it, a Vita Master as well as a Vita Classic shade. Depending upon your lab, you can just share it with your lab and the lab can use that information to create the prosthesis for you. Okay? Smile designing. Earlier, it was so difficult that how to explain to the patient what the final outcome will be. Today, moment we have scanned, we just do a digital smile designing for the patient and we can show it to the patient how the smile is going to look. You can do the entire thing digitally. We have the DSDs. You can see the pre-op, post-op. The patient can get immediately convinced the way his smile is going to look, how his face is going to look, how these new teeth will look onto his face is very important. So today we do face scans also in this and we completely digitize everything. That's how digital dentistry has come up to make a game change in our practice, to make our patients practice, to get convinced to high level of dental practice. Occlusal adjustments. One of the things that in my practice, digitization has helped in a great way. Earlier we had to put articulating papers, a series of these papers, understand whether this paper is actually giving the right mark. Did the patient bite properly? Am I using the right thickness of the articulating paper? We had all that problems. Today, I have an occlusal machine.
By Bausch.
See what happens.
The new OccluSense system, developed by Bausch, combines the traditional and digital registration of the pressure distribution of the occlusal surfaces. The OccluSense device is being used in combination with a 60-micron thin single-use pressure sensor coated with red color. The disposable pressure sensor is being applied exactly like a conventional occlusion test foil. The patient's masticatory pressure distribution is being recorded digitally in 256 pressure levels. The data of the occlusal masticatory distribution is being transferred to an iPad and displayed live in the OccluSense app. The traditional color transfer on the occlusal surfaces of the patient facilitates the assignment of the high spots to the pressure graphs shown on the iPad. In addition, the recorded data can be stored as 2- and 3-dimensional graphics, including the masticatory distribution, with up to 150 images per second.
So
the recordings are being stored in
the machine. I not only get the record where the pressure spots are, I'm getting a marking also in my patient. So look at this case. So much of a malocclusion the patient had. All I did is I did a scan of the patient. I put the patient with an occlusence, got the markings, got all the markings on my laptop, on my iPad, eliminated all of it, and the occlusion settled. How beautifully, just by simply doing occlusal equilibration. But this occlusal equilibration with my conventional technique was a challenge. But because of the digital tool, it has become a cakewalk. I'm absolutely sure where my pressure spots were, how to eliminate that, which one to eliminate. And once I eliminate, this is how I get the occlusion. Laboratory, a game changer again, I would say. Digital dentistry has changed the way our laboratory work is done. We as prosthodontists, it has been our dream. We used to do wax patterns and, remove the wax pattern, cast it, invest it, do all of it. Today, just a click of a button, you can do. There are basically, remember, two technologies which digitization uses in our laboratory. Either it is printing or milling. What is it? Printing is an add-on technique. Milling is a subtractive technique. Add-on means you create the prosthesis from a liquid. The printing, and milling is where from a block you mill out your prosthesis. So see how printing happens.
First, a digital impression of the patient's teeth and gums is taken using an intraoral scanner. Here we use Medit i700 wireless. The scans are then imported into a model builder software. In this case, we are using Medit Model Builder. In this software, we convert the mesh scans into a printable model. Once we are happy with the design, we set it up for 3D printing using the 3D printer's slicing software. We can now prepare the 3D printer. Here we are using the Formlabs 3B Plus printer, which uses printing cartridges. Insert the cartridge, make sure the build platform and resin tray is in place. Now initiate the printing process. Once done, the model is removed from the printer platform for post-processing. The model is then washed in 99% isopropyl alcohol twice and then cured. Here we are using the Form Cure. Lastly, the supports are removed. With any resin you are printing, you need to make sure to follow the manufacturer's guidelines. Your models are now ready. These can be used for a variety of things, such as thermoform appliances.
No plaster, nothing, no vibrators, nothing, no waiting time. Just scan, print, and your models are ready. You can use this technology not only to make your models, you can make your aligner plates. Here you can see you can make your aligner plates, you can make your restorations, or also your denture base. These are places where printing technology is being used in our prosthetic dentistry. Next comes to milling. Let's see what is milling. So this is how milling takes place. The entire prosthesis is built from a block. It can either be metal or it can be zirconia or it can be Emax. Today Emax is also milled. Today we have one Emax which is milled. Okay. Now there's something which is called as a multi-layered milling. What is multi-layered milling? From one block you can have the entire denture milled where the base is red, pink in color and the teeth are in white in color. That's where a combination of milling is happening. This is called as multi-layered milling. Or you can have a hybrid restoration where we have a printed base and we have a milled teeth which are then luted together, and it's called as a hybrid restoration. That's how today digital technology has helped us and integrated it completely into our practice. Okay. So what is it going to be? Dentistry today is going to get completely digitalized. It is the next form ahead. So dentistry henceforth will no longer be the regular thing. So let's understand what are the benefits of digital technology. It helps in communication. Absolutely. With a click of a button, you can communicate to your patient, to your consultants, even to your laboratory. With a click of a button, communication has become so easy. You have good quality. You're sure of what you're doing. You're absolutely sure what you have done. You can quality check your product because you have got the technology to do it. Next, archiving. As I said, even after 5 years, with a click of a button, I can get all the information that I wanted of my patient, whether it's an X-ray, with a case paper, with an appointment, what I have done, even a restoration. I've done a scan. I can, after 5 years, the patient comes, I just want to re-see what I have done, or I want to redo the same prosthesis. I can just do it without any problems. That's how archiving has become easy. Okay, and patient experience. The way the patients have today started enjoying because of digitization, which has coupled into our practice, is just phenomenal. Whether it is, like endodontics, today, there was a time when we were not sure, so we could not be very sure with our patients. Today, because endodontics has become more predictable because of digitization, we can be very sure whether it is prosthetics, or diagnosis, radiology, whatever it is, the patient's experience has become so beautiful. Patient can feel it. In ortho, as I said, you can show the patient can see his teeth moving. So he just loves this experience. Most of my patients have a wow experience after they see the way digitization has touched our practices. But there are certain barriers of digitization. You have to adopt to it. There's a huge learning curve. For me, as a senior practitioner, it took me a huge learning curve. Today, younger generation people, all those are young generation who've logged in here. It's so easy for you all because you all are very tech savvy, you all are software savvy. We are old people, we are old thought process people, we are analog people. We took a lot of time. And once the learning curve is done, it's just wonderful. It always raise a question of relative quality. Am I really getting the good quality? Is where there was a question. I'll tell you where it happens. Sometimes our fingers, our digital dentistry, this digital dentistry gives that, comfort level, that correction. I'll tell you, when I get smile designing done, a digital smile designing done, I'm not happy because I want certain corrections that I can do only with wax. So as a prosthodontist, when I'm doing my FMR cases, I like to have a wax mock-up because I can correct onto it, I can beautify it, I can give a personal touch to it. Okay. And complexity. Remember, it's a complex thing. Putting everything together, understanding all the portfolios, understanding all the technology takes a lot of time. It's a very complex thing and a huge investment. I showed you the digital articulator. You know what is the cost of a digital articulator? It costs 35 lakh. So it's a huge, huge capital investment. Today, a scanner is expensive. You all think, is it really important? But once you invest it, it gives good returns. So this is where and one of the biggest thing is whether we are sure of this robotic assisted dentistry. Remember, it is going to reduce human error, but at the same time, its predictability is becoming very difficult. Last, today AI and augmented reality is taken up very intensely again into this is the latest concept in digital dentistry. But there are a lot of practical applications in dentistry. You can absolutely, all your exercises can be done by augmented reality. You can show the patient augmented reality. You can discuss cases through augmented reality. You can perform cases through augmented reality. But remember, it all has a limitation. This is going to be dentistry henceforth, where the click of a button, there are going to be 4 patients which are treated through robotic arms. Is it so true? Just remember, don't become a slave of technology. We as clinicians have to expertise ourselves, be proficient in our work before we get into digitization. Remember, or else you will remember. So remember,
dentistry is a cooking type of profession. There's a recipe. I can do it one way, another dentist will do another way, another dentist will do another way. So for a dental student like I was, when I saw my one dentist do a procedure a certain way, it's like I learned their recipe. And then I went to another dentist who I really respected, and I saw his recipe. And I go, oh, so there's a couple different ways I can do this, right? So how do you make an apple pie? There's 100 different recipes. So over-the-shoulder learning, like a chef, when you watch a chef work, when you watch a dentist work, it's a project. They're making a project. Seeing that process as a student, it makes you understand that when you go to the clinic, you're going to be able to either copy it or get it close to what you're trying to achieve.
So that's very important, friends. Our learning and our hand-on skill is extremely important. However technology may come, do not think that because today there is technology, I don't need to do my wax ups, I don't need to do my teeth settings, I can just print, I can just mill. No, friends, dentistry is always going to be a cooking skill, the way he says. And I remember how I used to go to one of Dr. Makran Ezurikar. He's my mentor as far as my practice is concerned. I literally even today when I go to his practice, I stand next to him, see how he's performing, because it's something that I can bring back home for my practice. Remember that. And that is why I love cooking. Cooking is my passion. Nurul said a lot of things, but he did not know this. Cooking is my passion and I love to cook. And that is why I'm a good dentist, I would say. So thank you so much. I think so with this, I come to an end of my session. I would only like to share this that I'm not handsome, but I can give my hand to someone who needs help because beauty is required in the heart and not in the face. I have these courses. If anybody is interested, you can get in touch with me. I do FMR courses for 4 participants are allowed in this. So for this date, I have only 1 seat left. If anybody is interested, can get in touch with me. You can directly WhatsApp me and I'll get back to you. Of course, there's an advanced course also, which is only for members who have done the basic course of mine, which is now on the 1st and 2nd of November. In case anybody is interested, you can do both the things together. You can offer for that also. And remember, dentists in the year 3000 will be like this. What will be? Dentists will float into the clinic on hoverboards, only to realize patients still don't brush twice a day, even after 1,000 years of reminders. Okay? Yeah, AI robots will do root canals in 3 seconds, but patients will still ask, Doctor, will it pain? Cavities will be scanned by nanorobots. But people will still blame chocolates instead of skipping oral hygiene for decades. Toothpaste will come with built-in Wi-Fi and AI control voice assistance, but nobody will read the label. Use twice daily. What is more important? See, I've highlighted that. Patient will arrive in flying cars, but still won't arrive on time for your appointment. Dental chairs will offer full body massage, Netflix, and virtual reality, but patients will still say, I'm scared of dentists. Government schemes will cover intergalactic dental insurance, but payment will still be pending approval by your patient. Post-op instructions will be telepathically delivered, but people will still ask and call you, can I eat biryani now? This is what dentistry will never change, friends. Though, however, technology we put into it, it is going to be just the same. Thank you so much. It was such wonderful. I hope I am able to touch up all of it in the 20-25 minutes that were given to me. Have I done? Yeah, I have covered up. I hope I've not overshoot my time. Thank you so much once again, the organizers, for giving me this opportunity. Any questions?
Any questions from audience? Dr. Ratin is with us. You can ask the questions. See how the modern dentistry is all about. From Dr. Jain and then Dr. Ratin and then Dr. Shaban, we are all seeing that how dentistry is progressing in leaps and bounds, and we are far from the conventional dentistry. So it's all what we are doing in hours, it is being done in minutes with more precision, with more accurate with us. So, and again, you see, dentist should be like a chef actually. They have everyone have a different recipe and all. So you have spoken about biryani and all. So everybody, the dentists have to, make their own recipe to, heal their patient to reach the objective and all. Dr. Ratin, you are not audible. Meanwhile, anybody want to ask any question, they can put on the chat box and ask the question again. And Dr. Natin, I'll pass on your, the course to the, our all aspirants who want to join your course, because there is a one berth left actually. So I think you might be getting from our participants only. You unmute, Dr. Natin. You are not audible.
I am not unmute.
Yeah, you are audible now. Yeah, you are audible now. Yes.
Yes.
So, how is weather in Mumbai, Dr. Ratin? Again, you are means you become your microphone go into mute mode actually. No, sir, you are not audible. There might be a the signal issue actually.
Maybe signal issue because
Yes. Now you are audible.
I can hear you.
Ha.
In Mumbai is bad. It's pouring very. It's
No, you are audible. Continue.
pouring very heavily. That's why I got a little delayed. I was worried that
Yes.
I called you up also, but I could manage it.
Okay. Okay, Dr. Ratin, with your permission, should we move on to our next speaker because we have two speakers left for today?
Go ahead, please go ahead. Thank you so
Yeah.
much.
So nice of you, Dr. Ratin. If you get the time, I request you to join tomorrow as well to guide us
Tomorrow?
and to have a discussion and all. Yeah,
Sure, sure.
sure. Yeah. Okay. So we are moving to our next speaker, Dr. Anupriya L. I am fortunate that I am introducing her. She is from my alma mater, Aligarh Muslim University. I did my graduation in 2003 from Aligarh Muslim University, AMU. And Dr. Anupriya too is working as a clinical registrar, senior resident there. And she has in a department of oral and maxillofacial surgeon. So she is an oral surgeon, and she owns expertise in the field of oral surgery. She has various national and international publication and is very active member in academics as well. So, Dr. Anupriya, you are throwing some light on AI on dentistry. Dr. Ratin has already discussed a lot, but being a
Yes.
young dentist, because you are having more tech pro actually. So the young people are bringing more energy, more IT into the AI in the field actually. So over to you, Dr. Anupriya. Your slides are visible. You are audible.
Okay.
So you
Hi,
can
sir. How are
continue.
you?
I'm doing good. How are you?
Yeah. Great, sir. So nice to connect back to you. And it's
Yes.
a great pleasure to be back to the same. I think last year I was as a host, like I was one of
Yeah,
the,
yeah. And you are
I was
there is some
hosting.
there is
Yeah.
some climate and there is a weather issue actually. So your connectivity is not pro actually. So now you are at that time. I think you were in Chennai
Yeah,
somewhere.
I was in Chennai, yeah, and it was flood in Chennai that time.
Yeah. Yes.
So yeah, but right now, like I'm practicing in AMU, the alma mater. Like it's your alma mater, same
Yes,
as
of
mine.
course.
Yeah.
Yeah.
So
Okay.
it's yes, sir. Thank you so much, sir. Yes.
Yeah. Continue.
So yeah, a warm evening to everybody, and I think Ratan sir has just thrown us so much light and with so much knowledge and everything. He has told us everything about the current digital dentistry, right? From oral medicine, oral diagnosis, till the implantology part. Like, sir has really covered everything. So today, like, I'm just gonna throw in some light of like where, like dentistry with AI. What are the other things that we can do in our dental clinic with AI? Like, so where precision will help meeting us in progressing. So what is basically AI? AI is nothing, it's just a machine or it's just a computer that is programmed to think and to learn like humans. So am I audible, sir? Hello? Hello? Oh, can someone just confirm me?
Yes, you are
Hello?
audible.
Yeah. Okay, sir. Yes. So the examples of AI in real life is that like we call Alexa and Siri in every house, like Alexa turn on light. So that is also AI based. And we have a Google Translate for every language conversation. Like we go to a new place, like we just talk and we just show it to that person and they just understand it. It just translates in their own language and we just get replied in our own language. So that is also AI based. And chatbots and your self-driving cars of Tesla, all this is AI based. And when you open Netflix, the first thing that it's going to show you is that since you watched movie this, now I'm recommending you movie this. So all this is all like AI based. And so AI dentistry is currently like very rapidly evolving with technological advancements. So the artificial intelligence, it plays a crucial role in modern dental practices. And in this, I'm just going to highlight few key areas where AI is going to help with us. So how basically this AI works is that like AI, it works by mimicking the human cognitive functions such as the learning, reasoning, and problem solving. Like the AI is being fed with so much of data, like 10,000, 20,000 of data into their system. And using those already available system, the AI gives you information when you're going to ask it a question. So there's nothing that AI it's going to do something new. It's going to do the same thing that you have already given it to it earlier. So from streamlining diagnostics with deep learning models to providing virtual assistants that enhance patient engagement, AI has become a powerful ally for both the clinicians and for the patients. So as AI continues to evolve, its integration into dental workflows is expected to improve clinical outcomes, reduce human error, and make dental care more accessible and efficient worldwide. So this is just a comparison between the traditional dentistry and the modern dentistry. In the traditional dentistry, like the diagnostics were of like X-rays, and it was subjective, like the subjective from person to person. For some person, like there will be widening of lamina dura, but for the other person, they said no, it's normal. And to come into a conclusion, it was also time consuming. But in case of AI, it just shows you that no, here there is a caries, here there is a periapical abscess, and it is automated and fast. Within minutes, you're going to get the diagnosis. Like, not even minutes, within seconds, you're going to get the diagnosis. So there are softwares called as Pearl and DiagnoCat that is going to help you with that. And in case, same like in case of treatment planning, like it based on the dentist manual assessment and experience, like as they say, like each surgeon have their own skill set. So same way, each dentist have their own type of doing. Like some people will go for missing tooth. They say like RPD is better. Some people prefer for FPD, but the current technology is implantology. And in implants also you have basal implant, you have single stage, you have double stage. But at the end, we don't know how it's gonna uh, result, like in which patient, what is the outcome, what is the prognosis. The AI helps you with this precision planning with 3D simulations and data driven recommendation. When you're going to feed it with data of the patient, like this patient has diabetes, the bone quality is this, so this is going to be the treatment. So it gives you the prognostic that how much success of your treatment is going to come. And then the patient engagement is limited to in-person visits and in phone calls. Whereas in AI, like 24/7, you are available. Like the AI chatbots are available. So the patient have any concern, any questions, they can just message, and with the data that the AI already has. So with that, it's going to answer the patient, and it's not going to prescribe medication, obviously, but it's going to at least tell the patient that don't worry, it's not something that it's really, it's going to matter now. And efficiency and workflow in case of manual scheduling, billing, and note taking, it's very time processing in case of traditional dentistry, but automated, it's gonna be very fast. And education and training also, like mannequin practice, this again I'm going to explain in detail. So the application from diagnosis, so AI right now, it's just the tip of the iceberg. So the visible benefits, and it helps in the clinical improvements. The technological feature is going to help in enhanced image analysis and early detection of caries and periapical pathology, which helps in improved accuracy of the diagnosis as well as in the treatment. And moving on to the treatment planning, I'm just going to give you an idea about it. So what it basically does is that the AI helps in analyzing the patient data, including images and medical history, and it suggests some personalized treatment plans. As I said earlier, depending upon the patient's condition, it is going to say that this type of implant is going to be better for this patient. And in case of your orthodontic planning, the current Invisalign market is fully AI based. So they just work on this AI to simulate the final tooth position before the treatment even starts. So they are going to show you in the photo, like this was my before, this is how your before photo is there, and this is how you're going to look after 1 year or 6 months, or the time that is going to take. Everything, it's the Invisalign app, the completely works on your AI only. So next is that it helps in predictive analytics for the patient outcomes. Like AI analyzes the patient history, habits, and risk factors to predict the likelihood of caries or gum disease. And it helps in suggesting preventive treatments or hygiene routines to improve long-term treatment successes. So so the example is that when a patient is at a very high risk of implant failure due to bone density or smoking, the AI is going to tell you that like because of this bone density is like so, hounds feel less, so this implant is going to fail in this patient. So, and the other thing is that a study was conducted by a dental network, and they used AI to identify the high risk patients. And this, what happened to this study was that after like uh, few months, like they were able to assess the high risk patients, and they had reduced because of identifying these high risk patients, the emergency visits were reduced in their proactive care by means of 15%. So this was a study conducted in the University of Michigan. And next, we have AI-powered virtual assistants and chatbots. So this virtual assistants already, like, you're gonna feed the tool with saying that if there is post-extraction instruction, the patient forgets even the smallest thing. So after going home, they just feel that what should I do now? So this virtual assistance helps the patient in case of your post-extraction instructions, or in case of any symptoms, like if they might say that no, my LA effect has worn off now. So after 2 hours, the virtual assistant will say like, yeah, after two hours, it's gonna wear off. So you have to take your medication. So that's how the virtual assistant is gonna help the patients. And also by this, like the phone call that the patient is gonna do to the doctor is gonna get reduced. So the AI chatbots enhances the communication and education to the patient. How? By answering the patient's questions about their symptoms, the post-op care, and their following appointments also. And it also sends reminders for checkups and for treatments. Then one more thing the AI does is that it reduces the workload of the front office desk by managing the file and managing the billing, and automatically like providing whatever the payment has been done. So the American Dental Association Health Chatbot integration into various dental clinics has led to a 40% reduction in phone call volume, which by indirectly, like it has improved the treatment time for the doctors. Like it has provided more treatment time for the doctors. And next we have AI in administrative and workflow automation. So in administration, like as I earlier said, like it streamlines the operation. Like it does it in a very streamlined manner. Like when one patient comes for this patient, like first you have to go for this X-ray, and followed by like the preliminary impression has to be done, followed by the next step is going to be your oral prophylaxis, then followed by your implant or your caries, or so it helps in streamlining the procedure, and thereby it reduces the human error. Say if we are going to have an assistant in the dental office, so they are going to miss out this stages at some point of time. So but AI is not going to say do it wrongly. So it helps you to streamline your procedure. And it helps in automated processes like the automating billing and insurance claims. In India, we don't have this insurance claims that much, but in US and the other countries, like insurance claims are very much available, and it helps in the record keeping also. And there is one more function of AI is that it recognizes your voice, the conversation that you're going to have between you and the patient. It's going to transcribe, and it is going to store it in its in its system. And when if you're going to say you have to do this, and the patient forgets that, and they go home and they are going to ask the virtual assistant, what did the doctor tell me? So by this voice recognition method, the AI can help the patient repeat whatever the doctor had told the patient during the appointment. So by this way, like it's gonna improve the patient care. Like obviously humans we forget, but the AI is gonna help the patient in recollecting and in providing the information that was told by the doctor himself. And then we have the inventory management. Say your clinic is using so much of LA, or it is using so much of zinc phosphate cement or GIC or composite. So it is going to have a note of saying that this sort of cement is going to expire by this month. So you should not, you cannot use it after that. So you have to replace it. So all this, the inventory, the AI can manage, and it can help you in providing proper and a very healthy dentistry, healthy treatment to the patient. And and one more use is that like when you're doing the procedure and you forgot the working length of the patient, or you want to know the working length that you measured during the previous appointment, so you can just ask the AI saying that just tell this is the patient name with this ID. Just during the procedure, like while doing the procedure, you can ask the AI just by voice assistant, and the AI is going to provide you with that information. So this allows you a very hands-free documentation. And then AI, it can be used in dental education and training. So all of it, like during our BDS days, we would have done procedures in our manicures and in the models and everything. But right now, the time has come where like virtual simulations of procedures are being done, like in the US, in the University of Michigan, and in other dental schools of Royal College of Surgeons, everywhere, the virtual simulation model had come up, which helps the doctor in doing precise procedures and to learn from it. And by doing so, if we are doing anything wrong, or if we are lacking any accuracy, or if we are breaching the technique, then the AI is going to give us a feedback then and there. So by this, like we can correct our mistakes then and there, and we can improve on our hand skills. So the virtual simulations of procedures help is done by AI, and it also gives us feedback on the technique. And finally, the AI can even teach you, like you're gonna load the AI already. You are gonna load the AI with so many books. So from that, it has got its data, and the AI can guide you learning with personalized support. Like if you're gonna say like I cannot do this procedure, and the AI will help you in treating that particular procedure. Say for example, like you want to know how to give an inferior alveolar nerve block, so the AI can teach you how to give an inferior alveolar nerve block. So this VR-based dental simulators use AI to evaluate students' performance, and it also suggests improvements. So by this way, like within like few years, by 2050, or I don't know, in the near future, all the teachers and everybody are going to be supported with AI. AI cannot replace humans always. Like AI, you can support humans. So by this way, the students also can have better learning, and better hand skills will be improved with the students. And finally, there is the teledentistry is something that has come up, like telemedication has come up after COVID. So same way like teledentistry, you cannot treat the patient, but you can assess the patient by means of the photos or the videos that they are going to send you. So this, you will have a diagnosis, and the AI generated software also will give you a diagnosis. So depending upon these two, you can just symptomatically treat the patient. But anyway, the final treatment has to be done in the dental clinic only. And this also helps in triaging cases to determine urgencies. So I have attended patients in trauma center emergency at 12 o'clock saying that they have a very bad pain. The patient is complaining of pain, so come and attend immediately. So they just call us, so we just go there, and we see that it's just the dental caries. Like at 12 o'clock in the night, like nobody is going to give me an air to relieve the pain or to remove the caries. So all this can be uh, done in through AI teledentistry, so that the travel for the patient is also avoided, and the doctors travel and triaging the urgency. So that same time, like there was another patient who was bleeding from due to RTA, like road traffic accident. And so instead of attending this patient, I could have attended the patient who was bleeding, and I could have given more time for them. So this sort of triaging is very helpful in case of teledentistry. And it also supports dentists in rural and unserved areas, like where there are like no doctors. There are villages in India where there are no doctors, not even dentists. So in those areas, like if the teledentistry is going to reach, at least the emergencies can be handled immediately. So every pros comes with a cons. Cons. So same way, the disadvantage of AI in dentistry is that it's a high initial cost. The softwares and the tools are very expensive to implement and also to maintain. Then the data privacy concerns, the use of patient data for the use of patient data for AI analysis raises potential issues around privacy and concern. So, dependence on technology is also there. Over resilience on AI may lead to reduced clinical skills or human oversight. So, the lack of human touch, the AI doesn't have any empathy and cannot replace the personal interaction critical in patient care. Always, the personal interaction will give a better trust towards the patient as well. And there is always a bias in AI models. Like if the training data, as I said earlier, like you load the AI with so much data, and with that data only, it is going to give you information. So the loaded data, if it is going to be insufficient or if it is not going to be compatible with your population, like the Indian population, so the AI systems can produce biased or inaccurate outcomes. And finally, the regulatory and legal challenges is that the liability in AI assisted decisions can remain unclear in many jurisdictions. And it is going to take a lot of time for the law of court to accept this thing. So the conclusion is that AI transforms the landscape of dentistry. So it enables a faster, more accurate, and patient-centered care. So the future developments promise very even greater impact. So with this, I would like to thank you for giving me this opportunity.
Thanks, Dr. Anupriya, for summing up and giving the how the what is the role of AI and also the challenges and limitation as well. Anybody from audience want to ask any question, put any question before Dr. Anupriya, they can ask right away, or they can write on a chat so that. So there is no any question as of now, Dr. Anupriya, but stay with us. Maybe if there any question is coming post Dr. Anam's presentation, we'll come back to you. So with your
Sure,
permission, we are moving
yes,
to the
sir.
next speaker. We are just say 8-10 minutes lag in our program. So we
Yes,
are
yes.
fortunate that generally what happened that sometimes we are lagging say 40 minutes, 1 hour, but we are concluding on time. So we are really
Yes,
thankful to
yes.
our speakers. They are very disciplined. They are summing up their all presentation in a stipulated time and all. So thanks, Dr. Anupriya. Stay with us. We are going with the next speaker.
Yes, sir. Thank you. Thank you so much, sir, for this
Yes.
opportunity.
So we have the next speaker, Dr. Anam Rahman. Dr. Anam, say hello. Just unmute.
Hello, so good
Yes.
evening,
Yeah.
everybody. Am I
You,
audible?
you are audible. Yes. So
Okay,
Dr. Anam, she
nice.
is from Alamin Dental College, and Alamin Dental College is our academic partner. So we are jointly organizing this program. And just to introduce you, Dr. Anam, that Dr. Anam Rahman, an accomplished clinician and academician who currently serves as associate professor in the Department of Conservative Dentistry and Endodontics at Alamin Dental College and Hospital, Vijaypura. With a solid background in clinical practice and over 3 years of academic experience, Dr. Rahman is widely respected for her dedication to excellence in patient care, her passion for teaching, and her keen interest in advancing the field of endodontics. Her contributions to research, undergraduate training, and clinical innovations have made her a valuable voice in a dental fraternity. Today, we are honored to have her share her expertise at Iddcon 2025, where she will be speaking on massive endo failure with 3D fusion. Her insightful approach and commitment to continual learning make this session one not to be missed. So over to you, Dr. Anam. Thanks for providing us your brief introduction so that it will be very easy for us to introduce you as an organizer, because sometimes speakers are sending very lengthy profile and all, and it's very difficult for us to what we should pick and what we should leave actually. So it's very great that you have
Very nice.
shared a nice brief introduction. So over to you, Anam. Being a endodontist
Yes.
and a conservative dentist, you just throw the light that how this 3D taking a role in betterment of this patients and all and the better outcome. Over to you. I have
Thank
made
you,
you a
sir.
co-host, so you can share your slide. And if I
Okay,
missed anything
thank
in
you,
your introduction,
sir.
you can add on.
No issues, sir. I'm humbled, I'm grateful, and yes, hello everybody. Good evening. So yes, already we are running short of time, so I won't take much of your time. But yes, I am glad I was listening to every session being produced. It was an insightful session indeed. So yes, without much delay, I'm going to start. Okay, okay. Share. Mhm. So is my screen visible, sir?
It's visible. We are looking. Yes, your slides are visible.
Is it visible now?
It's visible.
Okay, sir. Okay.
Hmm.
No issue. All right. Yes. So good evening, everybody. So today I'm going to talk about mastering endo failures with 3D fusion. Intraoral scan meets anatomy based PCBCT. And yes, we have to deploy to retrieve, not destroy it. So yeah, the topic which I'm going to address today is an evolving frontier. It is not yet fully integrated into clinical protocols. But yes, we do have tools, technologies, and yes, conceptual framework. See, it already exists, but what we lack is systemization, validation, and training. We do have the capabilities, we do have the tools, but what we lack is systemization. So yes, this is my topic today. So what it is first, what CBCT does, as we have already seen our speakers, that CBCT reveals misanatomy. Intraoral scanning shows exact crown morphology. Matching both can correlate access errors with internal root canal deviations. Then, I do have a case study to represent, which is guided endodontics, accuracy of access cavity preparation, and discrimination of angular and linear deviation on canal accessing ability, which is an ex vivo study. The background is guided endodontic technique has been introduced for years. Accuracy in different types of teeth has yet to be assessed. So this study was basically done to evaluate for access cavity predictive ability of angular linear deviation on canal accessibility in vivo. What was the method used? We took 84 extracted human teeth that were mounted into 6-tier models, categorized into 3 groups. That was anterior teeth, premolar, and molars. Pre-operative cone beam, computed tomography, and surface topography were taken and matched. How it was matched? It was matched using implant planning software. Virtual access cavity planning was performed and templates were produced using a printer. After access cavities was performed, the canal accessibility was recorded. Post-operative CBCT scans were superimposed into the software. Coronal and angular linear deviations and angular deviations were measured and evaluated with non-parametric statistics. The receiver operating characteristic curve was used to evaluate the predictive ability of angular and linear deviation for canal accessibility in SPSS versus 20. What were the results? The results were a total of 117 guided access cavities were created and 23 of them were recorded as canal inaccessibility. But all canals were accessible after canal negotiation. The same results were found in linear deviation at the apical position, in angular deviation. And what was the area? The area under the ROC curve was 0.975 in angular deviation, 0.562 into the linear deviation at the coronal position. What was the conclusion of that study? In conclusion, this study demonstrated that the accuracy of access cavity preparation with 3D printed endodontic guides was acceptable. The linear and angular deviations in the M group were significantly higher than those in the other groups, which might be caused by the interference of the opposite teeth. Angular deviation best discriminated the canal accessibility of guided access cavity preparation. See, this is the graphical abstract, which shows guided endodontics, that is, accuracy of access cavity preparation and discrimination of angular and linear deviation on canal accessing ability and ex vivo study. So this is the abstract of the study which I'm talking about. What it is, we do have virtual access cavity planning, that is pre-operative, how it looks, virtual planning, post-operative, and then there is superimposition. Now, what does the colors indicate? Green cylinder indicates the virtual burr position. The red cylinder indicates the actual burr position. CD indicates the coronal deviation. And what does AD signify? It states apical deviation. A says angular deviation. What is the discrimination on canal accessing ability? That is blue line that states angular deviation. Hope my slides are visible, sir. I need to cross-check. Am I visible and am I audible?
Yes.
Thank you, sir. Thanks for the confirmation. Yes. Green line is apical linear deviation. Yellow line is coronal linear deviation. What were the methods? The methods were in present study, all methods were carried out in accordance with Human Subjects Research Act, and informed consent was obtained according to the scope of human clinical trials, that is exempted from informed consents of subjects in Ministry of Health and Welfare. And we got the approval, that is the ethical approval was obtained by Institutional Review Board of Koshang Medical University Memorial Hospital, which is outside India. So yes, this study was carried outside in the hospital. 84 extracted permanent teeth were collected, including 36 anterior teeth, 24 premolars, and 24 molars. All teeth were extracted, and why they were extracted? Because of the periodontal disease. It is not like we are extracting the healthy teeth. We are extracting the teeth which is affected. We also had endodontically treated teeth and teeth with extensive decay or restoration were excluded. Now, what we did, we collected the teeth. Now, secondly, what we had, all teeth were mounted in 6 stone models, including 3 maxillary models and 3 mandible models according to their anatomic position from central incisor to second molar. Now, what we did for all models, we took a pre-operative CBCT with a voxel size of 150 microns. That was performed. And then the data, where it was saved in digital imaging and communication in medicine. Now, all the models were scanned with an intraoral scan, and surface data were saved in the stereolithography file. Both types of data were superimposed in dental CAD software. Now, what we did, we took a burr, the endodontic access burr, which was used for virtual access cavity planning. This burr has a tip diameter, how much? 0.5 mm, shank diameter of 1 mm, and a working length of 16 mm. A virtual image of burrs 0.5 mm in diameter was planned using the software. We are not planning manually. We are using software. So that is why digital dentistry is coming into use. And a virtual burr was placed. We have placed a virtual burr using the software 3 to 4 mm below the CEJ with the axial within the range of the conservative endodontic access cavity. Of the 84 teeth, 36 virtual burrs were positioned in anterior teeth, 33 burrs in premolars and 48 burrs in molars. Now, for example, in premolars and molars, canals with complexity were excluded. We are not taking the complex cases first. We are taking the easy cases first. Of course, because for any study, easy cases give better results. Then we will slowly progress to complexities. We can't start with complexities beforehand. Isn't audience? Now, this is the image which I am showing is of virtual planning in implant software. That is a virtual access planning, 3D image reconstruction of cone beam computed tomography and virtual burrs with access within the range of conservative endodontic access cavity. The second image shows template with resin sleeve designed in software. Third, the image is of virtual planning of a premolar. I'm sorry. Then, now the colors, what the colors indicate, the template that is orange outline, that shows, that is the template, which is in the orange outline. The red outline, which is there, that shows the scanned surface. What is the virtual burr? The yellow cylinder, which is visible, that is the virtual burr. And cone beam computed tomography was superimposed in software. So what we do? After virtual planning, the templates were designed using software. Which software? It was a guide designer Intiware that is in Chiai, Taiwan. So of course, basically, we are well aware that whatever softwares are coming into the market, and of course, we do have conferences and the World Dental Show, which is organized in Mumbai. We might have noticed that most of the companies are from Korea or China or Taiwan. It is from those countries. Yes. 12 templates were created in STL file format and fabricated with a stereolithography 3D printer. Then that support materials were generated using software with density set to 1.0 and point size set to 0.7 mm. After the support materials of the templates were removed, all templates were washed with 90% alcohol, then post-cured using 405 nanometer light source for 30 minutes. I can understand, audience, it is very dry topic, it is hypothetical, but it is interesting, trust me. Then all models were mounted in dental simulation units with the opposite jaw model to simulate the clinical situation and operated by a single endodontic specialist. Enamel within the area of the conservative access cavity was removed with a round diamond bar until the dentin was exposed. The usual cavity preparation which we do. But until the dentin was exposed and templates were then attached to the models, the burr was used with low-speed handpiece to penetrate through the sleeve of the template with a pecking motion until the burr hit the mechanical top of the resin sleeve. Now the burr, what do we do? After doing a procedure, the burr was cleaned with gaze, irrigation with sodium hypochlorite, and yes, was performed out every 2 mm during drilling, and the burr was replaced every 10 canals. Not a single canal, not 2 canals, not 3 canals, after 10 canals. Now, after guided access cavity preparation was completed, each canal was segged with a size 10K file to evaluate the canal accessibility. If the K file could reach the root canal through guided access cavity preparation without any resistance, the procedure was deemed a canal accessibility. Otherwise, it was deemed if we can't reach the normal procedure, right? That if we are able to access it, if we are able to reach the canal, we say that yes, the canal is accessible. If it is not, what do we say? That the canal is inaccessible. Okay, now the post-op CBCT. We have taken the pre-op CBCT, post-op CBCT of all models were performed. What did we do? All data, including those of pre-op and post-op, oral scans and virtual planning were imported and then they were superimposed. Where they were superimposed? In a 3D slicer. Now, superimposition was performed using the fiducial registration module in 3D slicer. Models are marked with same landmarks, that is incisal, mesial incisal edge, canine and premolar, that is buccal cusp, Molars means your buccal cusp, both in pre-op and post-op CBCT, and the module will generate a linear transform according to landmarks to superimpose pre-operative and post-operative CBCT. Now, the angular and linear deviations were measured in a 3D view, as my topic says, 3D fusion. So the angle between the virtual burr axis and the actual burr axis was defined. What is now many of us might be having a doubt that what is angular deviation? The angular deviation is the angle between the virtual burr axis and the actual burr axis. The distance between the bases of the virtual burr and the actual burr was defined as coronal deviation. So yes, we know the definitions. We know what is angular deviation and coronal deviation. Distance between the bases of the virtual burr and the actual burr, I would like to re-emphasize that it is defined as coronal deviation. And the distance between the tips of the virtual burr and the actual burr was defined as the apical deviation. And the angle between the axis of the virtual burr and the actual burr was defined as angle deviation. The terms might sound very confusing. Trust me, it was confusing for me as well, but of course, this is going to be the future. Or this is to be more precise, if we modulate both CBCT and 3D scanning and intraoral scanning, if we merge them, we are going to boom the dental industry, especially in endodontics. So yes. Now, this figure, what this image states, there is superimposition of clinical pre-operative and post-operative images. Now, what does this figure, the first image says? It says it is the clinical photograph of the right lower first molar after enamel removal. We can see the dentin and template is drilled. We can see this. Secondly, 3D reconstruction of post-operative bone computed tomography, the second image. Yes, kindly lend me your ears, kindly lend me your eyes, audience. That is virtual image of burrs, that is green cylinder. What we see, that is the virtual image of burrs was superimposed on 3D reconstruction of post-operative CBC. Now the fourth picture that is D, that is the axial view of the post-operative CBCT burrs. I'm very sorry. Then sagittal view, that is the fifth picture, that is E, that what it says, sagittal view of pre-operative CBCT. The fifth one, that is the sixth one, that says F, it is sagittal view of pre-operative CBCT with virtual burrs. That is the green cylinder again. Wherever the green cylinder, it is the virtual view. Okay, now the G is sagittal view of post-operative CBCT and the parts of drills penetrated into mesiolingual and distal canal. H, that is the eighth and the last picture, it says that it is the sagittal view of post-operative CBCT with virtual burrs. So again, we can see the green cylinders. I told you, the green cylinders means virtual burrs. Now, there is slight deviation was noted. What happened? Slight deviation was noted between virtual burrs and the parts of drills. Okay, next we have this image. It is a 2D schematic figure that shows what it shows. It is measurement of angular and linear deviation. Now, what does red dotted cylinder means? It is the actual burr position. Green dotted cylinder, what does this say? It is virtual burr position. Now, what is CD? As told, what's coronal deviation? AD is apical deviation. And what is A? A is angular deviation. That's why I did not, even if I mark this with AD, we will be confusing it with apical deviation also. So A says angular deviation, AD says apical deviation, CD says coronal deviation. Next, now, teeth were categorized into three groups. That was anterior teeth, AT, premolar, and molar. And this study, where it was done in New York, in US. Now, non-parametric statistics were used and the significance level was set at 5%, P less than 0.05%. Receiver operating characteristic, we will be seeing the curves further. Receiver operating characteristic curves were used to evaluate the predictive ability of angular and linear deviation for canal accessibility. So yes, we've seen the curves. The results I have already spoken about, that it was 117 guided access cavities were created in 84 teeth and 23 guided access cavities were recorded. All these are statistical data which is being tried and tested. Yes, this is the table, like how we got coronal linear deviation, mean, standard, is mode of statistics. Also, apical linear deviation, which is recorded, we do have records. And yes, angular deviation, mean, standard deviation, minimum. Okay, so we do have statistics we do have box plots. Of course, because any studies we do, we use box plots and all. Box plots of linear and angle deviation. Significant differences were indicated by asterisks. Now, what does the first figure say? The first figure, that is A, says this is the coronal linear deviation with 95% of confidence interval in 3 groups. Third is B, box plot of apical linear deviation in 3 groups. Third is box plot of angle deviation in 3 groups. So yes. Now, what we did, see the ROC curve, what I was talking about in the previous slides. To evaluate the predictive ability of different deviations for canal accessibility, the outcomes were illustrated with ROC curves. The area under the ROC curve was 0.562 in linear deviation for the coronal position, 0.786 for the apical position, and yes, this significance was noted. Very sorry again. Yes. Now, the discussions were relatively every early glimpse of research that applied the guided endodontics technique was published in 2015, long back, 10 years back. However, this article reported a 3D printing model instead of a 3D printed template, because you also might have observed that using models, much of the understanding we get rather than template. Subsequently, many articles reported on the guided endodontics. So there were many articles that were being on this study, how to manage the fields, how to manage this with 3D fusion, with using CDCP and combining it with IOS, that is intraoral scanning. Now, the literature indicated that the guided endodontics technique was clinically feasible for both anterior and posterior of access cavity preparation between the different types of teeth. So this is the disclaimer. Secondly, now it is like some ex vivo studies had described the accuracy. One study said we use a 1.2 mm diameter drill, that the mean distance between the axis of the virtual drill path and target point was 0.46 mm. So basically, we do have studies that show that yes, there is accuracy also. Okay, there was another research using magnetic resonance imaging that was comparing what between AT, that was anterior teeth, and P stands for premolar. Mandible and maxillary teeth. The mean angle deviation was 1.82 and the mean deviation ranged from 0.21 to 0.31 mm at the base of the bud and 0.28 to 0.4 mm at the tip of the bud. Now, the mean linear deviation, what we have studied is that it is close to the present study, both in coronal and apical position, but the mean angle deviation is lower than the present study. Generally speaking, the outcomes of the present study do not differ substantially from those of previous studies also. So basically, we are near to the outcomes. Now, the present study, we compare the deviations between anterior, premolar, and molar. All the coronal, apical, linear, and angle deviations were significantly higher in M group than in the other two groups. Okay. Now, for implant-guided surgery, the concept of intrinsic error of the surgical template was defined as the mechanical error caused by the burr cylinder gap, which can potentially affect the accuracy of the surgical template. Okay, and what the researcher proposed, that if the template sleeve length is 4 mm and the gap between the drill and the sleeve is 0.2 mm, the intrinsic error can be calculated to be 2.86 degrees using the arc tangent function. Now, different types of endodontic systems were also introduced, including sleeveless guide system, and dynamic navigation system, that is DNS. The sleeveless guide system uses guiding rails and cylinders attached to the handpiece to guide the direction. This technique requires less space above the occlusal surface and provides better visibility, which also we do want as a clinician. Then, coming to the ROC curves. ROC curves are usually used to evaluate the diagnostic test performances, but they can also be used to predict clinical success, such as when applied for evaluating the ability. Now, what is ROC curve used for? It helps us to assess the clinical success, the treatment success of the patient which we are treating. What a percutaneous nephrolistom according to different scores or for predicting successful weaning from mechanical ventilation according to different factors. In the present study, the ROC curve was used to predict the success of what? Of canal accessibility. Of course, because we as endodontists, if we get access to canals, we are very happy. And I think many of the endodontics in the room might be gelling up with my concept that before, when we were students, when we were studying, I was student also now, but yes, because learning never stops. So whenever I used to get a canal, I was very happy that yes, the canal is accessible, and yes, we are accessible. It is like, yes, I have won the war, it seems. So yes, in the present study, the ROC curve was used to predict the success of canal accessibility, which defined as reaching the canal through guided access cavity preparation. Now the areas, these are numerical data, where 0.562 in coronal linear deviation, 0.786 in apical linear deviation, and 0.975 in angular deviation. Therefore, angular deviation followed by apical linear deviation is that best discriminated the canal accessibility. Next, now, there are certain limitations. Studies come, studies go, but we do have limitations as well. So what were the limitations? Finally, the study had two limitations. First, this test was not performed on PCO meaning that the impact of related technologies on PCO teeth in different types of teeth remains unknown. Now, the M group, the molar group deviations were relatively high, and this may compromise the treatment outcome of guided access cavities in molars. Now, advanced research is warranted to study the relatively high error in the molar area, such as changing the sleeve design, extending the sleeve into access cavity, or using the extends metal sleeve. Now, what is the conclusion? Study demonstrated that the accuracy of access cavity preparation with 3D printed endodontic guides were acceptable. The linear and angular deviations in the M group were significantly higher than those in the other groups, which might be caused by the interference of the opposite teeth. Angular deviation best discriminated the canal accessibility of guided access cavity preparation. Within the limitations of the study, the results of the study could be used to remind clinicians to pay attention when using guided endodontics technique in molar area. Now, how the data has come. I have put the data that is available from the corresponding author on reasonable request. Now, what were the abbreviations used? 3D was three-dimensional. Then we do have AT, that means anterior teeth. T is premolar. M is molar. CBCT is cone beam computed tomography. ROC is receiver operating characteristic. PCO, what was PCO? I was talking about that was pulp canal obliteration. CAD was, of course, this computer aided design. Iddcon was digital imaging and communication medicine. STL was stereolithography. Now, coming to the conclusion, this topic is basically what I want to say is endodontic failures are no longer mysteries to be uncovered. They are clinical data sets to be reconstructed, analyzed, and reverse engineered. Reverse engineered, my friends, my seniors, what I would like to emphasize that it has to be reverse engineered. With 3D fusion imaging, combining CBCT, intraoral scanning, and digital planning, we are entering an era where failures can be virtually modeled, segmented, and simulated before any retreatment is initiated. Before going for a retreatment, we can virtually model them, segment them, and simulate them. Then by generating, how we are going to do that? by generating biorealistic 3D models of failed cases, including transportation, errors, misanatomy, and complex resorptive defects. We can move from reactive treatment to preemptive precision guided therapy. These models enable us to test strategies, select appropriate instruments, and even design customized surgical guides or regenerative scaffolds. Before touching the patient, my friends, folks, I am re-emphasizing the fact that before touching the patient, we can virtually model these things so that yes, we know how this treatment, how this reverse engineering is going to look before actually touching the patient, before using the hit and try method. Currently, as I have stated in the beginning of my talk, that this is an evolving frontier. It is not yet fully integrated into clinical protocols. We have tools, technologies, and everything, and conceptual frameworks as well. It exists, but what we lack is systemization, validation, and training, not the capability. We are capable dentists, we are capable dental surgeons. So, yes, we don't lack capability, we lack the systemization, validation, and training. And with structured workflows and collaborative adaptation, this approach could redefine failure management in endodontics, turning setbacks into digitally mapped, mechanically rehearsed procedures with far higher predictability and confidence. So if we predict that, yes, this is going to happen before touching the patient, we plan beforehand. So yes, we do have backup options that, okay, if this is going to happen, then we are going to do like this. We are going to treat the patient in this manner, not after touching the patient that this case has failed. What are we going to do next? If the patient, because we can see the patients can sue us, usually we have coming up across almost very cases we are having that patient is doing dentist, they are charging us heavily, whether in India or abroad, he or she is charging us. Why to bring that opportunity? Why to bring that? Because we are not perfect. We are not perfect. So yes, there are chances of human error. After all, we are humans. So yes, and we may not be there yet, but we are undeniably close. And with the right intent and innovation, mastering endodontic failures through 3D fusion won't just be a possibility, it will be our new standards. So yes, these were the references. Thank you. Thank you, folks, for bearing with me for this humongous amount of data, for listening so patiently on your weekends, because many of you might be having Saturday plans because it's a weekend today. So yes, of course, genuinely, we doctors don't have weekends, of course, but still Saturdays. Yes, so I have already projected that we can connect over this. This is my email, my Instagram handle, and yes, the contact number also. So yeah, this was my talk. Thank you everybody for bearing with me so patiently, for being so wonderful audience in this wonderful evening. So yes. Thank you, sir. Over to you. And I'm
Thanks.
indebted.
Thanks, Dr.
I'm
Anand.
indebted to
Yes,
my
yes.
college, to my hospital, and of course to you, the organization, sir, to the organizing committee. I'm indebted to for such an insightful session, and looking forward for more sessions as.
Yeah, Dr. Anam, we definitely have a more sessions because we are, we are just it's the beginning of digital dentistry. It will go a
Yes,
long way actually. So
it
slowly
has
and
to.
gradually we are, moving ahead. So far as our endodontics and the conservative dentistry is concerned, we are moving in the digital dentistry. So with this note, we are, we supposed to conclude at 7, but we are just 40 minutes delayed, but it's, virtual. So everybody is, I think, enjoying sipping tea, having, snack break and
It's
all.
a
So no
Saturday.
issue.
It's a
Yes, yes.
weekend.
Yes, of course. So, uh, uh, so uh, before we conclude, I'm just giving you the highlights of tomorrow's program. We'll start by 10 in the morning and we'll go till 7 or 7:30. In the morning, we start with the paper presentation program where we have the 5 students and 5 faculties from various dental college across India. They would be coming to present the papers. And we have very,
Yes.
renowned academicians who are judging, who are the jury. Dr. Trevel Pereira, he's a dean in D.Y. Patil Dental College. Dr. Nishan, Dr. Gulam Sarwar Hashmi, Dr. Aparna, Dr. Rohit, they would be, judging the papers. Then we have a very known, the laser divas actually, they know themselves. People know that Dr. Shanin Farishta, she is from Mumbai, and she is going to talk on lasers in day-to-day practice. Then we have galaxies of a speaker like Dr. Anisha Parmar, Dr. Sejin Chandran. He will talk about digital transition in oral implantology. Dr. Harshvardhan Arya, Sankalp Mittal, Dr. Puneet Batra. He is Dean and Principal of Manav Rachna Dental College, Faridabad. He would be joining tomorrow to talk on role of digital technology on cleft care. We have Dr. Abdul Hamid Attar, Dr. Abhay Lamba, Dr. Neeraj, Dr. Ashmi, Dr. Nitin Thomas, Dr. Rohit Agarwal, Dr. Mahendra Pate, Dr. Ramya, Dr. Pulin Saluja. So we have say 20 speakers lined up tomorrow, and the 20 sessions we would having. We start by 10 morning and we try to close it by 7. Today we have a very we have a thankful that we have all the speakers who are made their time. They have given their precious time. They have enlightened with their presentations and all. So it was a wonderful day today, and we are expecting the more engaging day tomorrow. We are not getting much questions from audience today. Today is the first day of the weekend. There might be a chances that few of the students or clinician, they are busy in their OPDs or in their labs or in their colleges and all. But we are expecting overwhelming response tomorrow. We are getting more live audience tomorrow. They would be connecting, interacting, asking questions, discussing and all. And that's why this is the objective of this platform, that we should connect,
Yes.
interact and all.
French.
So with this
Sorry to
note,
interrupt, sir.
yeah, yeah.
Sorry to interrupt, but just I wanted to say that when I came to know that yes, Anupriya ma'am is from your alma mater, that is Aligarh Muslim University, I was nostalgic because my parents also have studied. They are the alma mater of Aligarh Muslim University as well.
Oh, great.
I'm an Nordi. So yes, but of course they are not from the medical fraternity. They have their own domains. One is from English and one is from commerce. So
No,
yeah.
no
So
matter, no
I went
matter,
into
but yes,
nostalgia. Yes, Aligarh
yeah,
Muslim
yeah. So
University.
have you ever been in Aligarh Muslim University?
Of course, I have been when I was a kid. When I was a kid, I haven't been, but I'm looking forward that yes, I would love
Yes,
to
yes.
visit again.
Okay. No, no, we have, I am
Yes.
from the third batch of dentistry actually, 98 batch. In
Okay.
96, the medical college was started in AMU in 1960, Dr. Jawaharlal Nehru Medical College.
Yes,
But
yes.
the
Many
faculty
was
of
there.
dentistry started in 1996 actually. And I joined in
Okay, okay.
1998. Yeah.
Okay, just 2 years after that.
Yes, yeah, I'm the third
Okay.
batch. Uh, so,
Mhm.
so with this note, we are closing. Anybody want to add anything, ask any questions? We have very live audience. We have still, 10,
We
12
have
people are
12
there.
people.
Yes,
We
so
have
if
12
they want
people
to
again.
interact, they can, uh, you know, they can share their suggestions, the guidance,
Actually,
what
I
they
was
want to.
so much enlightened by Ratin sir's session.
Yes,
Ratin sir's, Dr. Shadab Khan sir's, this
yes.
insightful session that yes,
Mm.
digital photography and Ratin sir's last slide was interesting. So yeah, and of
So you
course,
are fond
Jen
of
sir's also.
biryani, so that's why you are saying.
No,
In the last
it was
slide, he mentioned
AI.
biryani.
No. But the last time it was saying that patients will come in flying cars, but still they will be late.
Yes, yes.
Like this, those punchlines were so good, and actually that will be the future. So yeah,
Okay. So with
yes,
the
sir.
permission of all audience, should I conclude and should I sign off for the day? And tomorrow we are joining sharp 10 in the morning with the energetic presentation from our students and some of the faculties with the upcoming there. They had did wonderful work. We have received some 70 papers, and it's very difficult. Our panels have selected 5 each from faculty and the students. So let's see how they did their work in digital dentistry and modern dentistry. With this note, I am concluding, and it's a very nice, it's a nice discussion today, and it's a very productive, fruitful. and we're expecting the same very productive and very interactive, very mesmerizing day tomorrow. So thanks to all for joining and sparing your time and joining International Digital Dentistry Congress. So we are joining tomorrow at 10 morning sharp. Okay, do join us, connect us tomorrow. Thank you. Thanks.